Hello, everyone. The breakfast is in the trays right there. You can feel free to eat. Thank you.
Howdy, everybody. Thank you all for coming today to our MHREACH Community and Key Stakeholder Collaborative Symposium. For those that are with us in person, there's breakfast at our left back corner. Feel free to get up at any point to grab yourself some food and have it at your desk. One other note is we are in the TSU University Museum, so please be mindful of the walls and the artwork on there to not bump into them or to disturb our artwork that we have here. And with that, I'm going to go ahead and introduce myself. My name is Cecilia Torres. I am the Center Program Coordinator for MHREACH. MHREACH stands for the Gulf Coast Collaborative Center for Maternal Health Research, Education, Advanced Training, Community Engagement, and Health Equity and Justice here at Texas Southern University. I also serve as an epidemiologist within our Center for Biomedical and Minority Health Research and assist with student and faculty data analytics and maternal health programming here at TSU. And I will serve as today's Master of Ceremony to help keep the flow of all of our projects. I'm going to go ahead and introduce to our stage Dr. Omonike Olale. She is our principal investigator and center director for the HRSA-funded MHREACH program. She also is a professor of pharmacology and the senior associate vice president of research and innovation here at Texas Southern University. Her formal training in pharmacology and epidemiology were at Johns Hopkins University School of Medicine and at Harvard University. Dr. Olale has expertise in pharmacology and epidemiology, research spanning over 20 years, working on research focused on diseases that disproportionately affect underrepresented minorities. She also serves as the PI for the NIH-funded Center for Biomedical and Minority Health Research. Dr. Olale.
Good morning, everyone. Thank you so much for coming. We really look forward to hearing more from our partners. Like Cecilia said, my name is Omonike Olale, and I would like to give a big shout out to our staff and our team, the maternal and child health team. Give it up for them right now. Most of them are wearing this pink shirt. They really made this work. Above all, they're the ones going out to the community to really move the needle. I would like to introduce our center, the Gulf Coast Collaborative Center for Maternal Health Research, Education, Advanced Training, Community Engagement, Health Equity, and Justice at Texas Southern University. It's a long name, but this is what we do at HBCUs. We make lemonade out of lemons, okay? We do a lot with very little, so we were so blessed to receive this funding from HRSA last October. The main goals of our centers is really to establish specific research projects that would tackle the current disparities that we have in maternal health. Our center is focused on two major research projects led by Dr. Ajewale. Give it up for Dr. Ajewale. She'll be speaking soon. And Dr. Ajewale is also a TSU alumni. And as I speak about Dr. Ajewale, my eyes is going to Lariana. Give it up for Lariana, please. Lariana is a TSU alumni, but more importantly, she was one of the first cohorts of our maternal child health training program here at the university when we had a funding with Baylor College of Medicine to train 20 students across 5 years. We ended up training over 125 students. Guess what? Lariana now is at Harris County Public Health. She's leading, thank you, Dr. Brown. She's leading the maternal and child health program. Give it up for her. Give it up for TSU, all our faculty. And you hear from her as well. So the second project is led by Dr. Kende Idowu. Dr. Kende Idowu, he'll be speaking about his project. And more importantly, we're going to, at the end of our project, would have deployed 8 pilot projects that are community-driven projects to address maternal and child health. And those will be led by Dr. Pounds. She has a big team, and they will solicit for applications. We will get community-based organizations to partner with our early-stage investigators here at TSU to tackle this issue, but more importantly, to deploy solutions to our community. So this is the focus of our center. As we build, we're looking to build things that are scalable, sustainable, we will build capacity, we will build systems, we will build structure. So we're really thinking big. So we look forward to partnering with you as we make all these great things happen. This is the team over here. It's a great team. I've been super blessed here at Texas Southern University. This is my 17th academic year. I think one of the greatest graces that God gave me is really to be partnered with great colleagues here, great colleagues, great students, to work alongside with me to as we move the needle for our mission at our university. All this started when DHHS reached out to Dr. Ajewole and I and said, hey, we would like you guys to host a conference for maternal health. And we literally told DHHS, we're done hosting conferences. We're done talking. Stop talking, get the work done, give us some funding. And I said, if you promise that TSU will get funding, and if you promise us that we can get a collaborative started here, then we will host whatever you're trying to host. And they gave us that promise. So I'm really blessed that we were able to gather our faith-based leaders, our legislative elected officials to join us for that opening discussion. And from that, we worked closely with 7 HBCUs across the country for 2 solid years, meeting every single Friday to talk about how our universities can do better to transform our communities, more importantly, to move the needle when it comes to maternal health outcomes. So we worked with those HBCUs, and out of the 7 of us, 5 of us got this fund from HRSA to move the needle. Give it up for those HBCUs, great leaders that are really making a difference in their community. More recently, we partnered with Dr. Susan Murphy to submit a UG3 to build out our CHW infrastructure. Also, the Texas Advisory Committee invited me to testify on this issue, and part of that work will be put together to present to President Biden as we look as a nation on addressing this crisis. This is the structure of our center. We have an administrative component. We also have the community engagement core led by Dr. Pounds. Give it up for Dr. Kimberly Pounds, which is also the co-PI of the MHREACH grant with Dr. Szymanski. Give it up for Dr. Szymanski. I'm so happy she was able to come, and we look forward to hearing about what everyone is doing. So Dr. Pounds is leading a big program for our community health workers. She's the one leading the community pilot projects, like I mentioned. She works closely with our community advisory board, which you'll see some of them today. Then we have the investigator development core and the training core, because our goal is not only to transform our community, we want to make sure we have a sustainable pipeline, and also there's workforce development. So Dr. Ivy Pond, give it up for Dr. Pond. She will be leading this effort. She also leads it for one of our larger grants, the NIH-funded grant, to train undergraduate students, graduate students, early-stage investigators, postdoctoral fellows, which we now have 2 postdoctoral fellows in our center. Can you rise? Our 2 great postdoctoral fellows, Grace and Jasmine. Come on now. Grace joined us from Texas Tech, and Jasmine is a TSU alumni passionate about improving maternal health outcomes. Also, Cecilia, stand up. Cecilia is our program coordinator and epidemiologist. But one of the greatest things Cecilia has done for us really is working closely with Dr. Poon to train high schoolers. Okay, when you're talking about a pipeline, it's not starting in college. It's starting K through 12. So we're so blessed to have Cecilia. Next, we have a research infrastructure core that will be working on those 2 big center projects you're going to hear about, Dr. Ajewole and Dr. Idowu. But also, the research infrastructure core will serve as an infrastructure to take on service projects, additional projects. And for the prospective study we're doing, Dr. Ajewole is working with somebody we're going to meet today, Voices of the Pregnant and Parenting Working Group. This part of the working group will be coming this afternoon as well, because we really want to hear from everybody, and not just hear from them. We want to partner together to move the needle. So we're really blessed to have a great team. This is just our framework. I won't spend too much time on it, but our goal really is, like I said, to train and to build infrastructure, to work with our community to deploy real solutions. as you know, the numbers keeps going in the wrong direction in this country, as a country overall. But even more importantly, for our Black mothers. Black mothers die about 2.5 times more than their white counterparts. So we're really addressing this issue at Texas Southern University. More importantly, on September 1, the Texas Maternal Morbidity and Mortality Review Committee released the data. And one of the things they shared, which you'll be hearing more later today from Dr. Onyego, who serves on this committee, is that they identified the top 6 leading causes of death among our mothers in the state of Texas. And of course, you will see disparities with our Black mothers, but more importantly, they were able to identify the top 5 contributors. And that's why we really wanted to sit with everyone at this table. Systems of care is a big problem. Providers, gaps in their service delivery, facility, and of course, there's an impact of the community, patient, and family. And being able as providers to deploy culturally responsive services to our mothers. So we're really looking forward to work with everybody. We have a small workshop that will deploy this afternoon to hear from you on that. Like I said, Harris County, we have our Harris County team. Please give it up for our Harris County team here. We're partners with them, looking to really get to this, but more importantly, move the needle. So this is the data from Harris County for our Precinct 1, for example, 56.8 deaths per 100,000 live births. Very devastating. So we will make sure that that's not the story in the coming years. Again, all of this started because Texas Southern University received a huge grant with Baylor College of Medicine, working across the country with 6 other MCH pipeline institutions. We trained those 125 students. We published papers. I believe the students had up to 20 publications on this work. They analyzed over 60 million pregnant women nationally. And so now our focus is, let's work with Harris County. Let's work with the Houston Health Department. Give it up for the Houston Health Department. They're here as well. And really resolve this issue. We worked closely with our grantee partners, not only just publishing the research outcomes, but really creating a framework for pipeline development as well in this country, mentoring and research as well. So we're so blessed. TSU has moved on to continue to build infrastructure, leveraging other grants. Our Vice President, Dr. Michelle Penn-Marshall, recently received the Department of Education grant to hire additional faculty alongside with Dr. Ivy Poon to bring in new faculty that have maternal and child health background and other areas as well. We're also working with Dr. Ajewale for the Gulf Coast Consortium. REACH, give it up for Dr. Ajewale. That's another grant she got. And this is really to help take products into commercialization, community solutions into commercialization. We also work with our UTMB teams to deploy some pilot projects. Give it up for Sharon, representing our UTMB team. Thank you so much, Sharon, for coming. We truly appreciate you. More recently, TSU purchased a mobile van, a mobile coach that will be able to deploy care to the community under Dr. Ajewale's leadership, as well as now TSU is now a clinical trial site. I wanted to say praise the Lord. Under Dr. Ajewale's leadership, with work with UTMB and mentorship from UTMB, Morehouse, Yale, Vanderbilt, TSU will now become, and funding from Pharma Foundation, a clinical trial site where we can be a liaison between our community and the largest medical center in the entire world. So it's amazing. We need to leverage the strengths of having that medical center to really improve maternal health in this nation, more importantly, in this county, in this state. Thank you all for all the great work you're already doing. And now you hear from the great team. Thank you so much.
Thank you, Dr. Olale. We're now going to be moving into our Community Engagement Core, led by Dr. Kimberly Pounds, who is a co-director for it in MHREACH. She also serves as the Associate Professor in the College of Pharmacy and Health Sciences and Health Administration program. Here, she trains health profession students in development of community-based programs. Dr. Pounds has over 25 years of experience developing programs that addressed disparities in health through community engagement and participatory methods. As a trained health educator and researcher, her work has addressed tobacco prevention and cessation, cervical and ovarian cancer survivorship, women's participation in chemo prevention trials, women's decision-making in health, and pharmacist home-based models, diabetes, and hypertension management. Dr. Kimberly Pounds.
Good morning. I want to introduce Kennedy Norwood. She is the MHREACH community health worker. She is from the class of 2024 and a recent graduate from the University of Houston. So we couldn't do the work that we do in the Community Engagement Corps without Kennedy's expertise. So the main goals of our Community Engagement Corps in the MHREACH is first to engage the community. And we are trying to engage both people who have lived experiences and unfortunately have bared the burden of unfortunate circumstances and birthing outcomes. We also want to engage people who work alongside these types of patients. So we're engaging both professional and people with lived experiences. We also want to build the capacity of community organizations to be able to address these maternal health needs. So one of the things Dr. O mentioned earlier is that we will be rolling out a community pilot program where we will fund organizations to do the work that they do in our communities. Disseminating our outcomes, Kennedy and I, along with Dr. Gwynn and Dr. King, the other members of our team, will be working to make sure that when we have results from studies, that they're packaged in a way that our communities can not only understand the information, but possibly use it in their advocacy work as well as their daily lives. And lastly, we always continue to evaluate our efforts. And I'm going to put in a shameless plug because you are going to get a survey at the end of today's program or tomorrow. So please fill it out because it helps us to kind of keep our finger on how well we're doing in engaging the community. This is our fantastic community advisory board. They are made up of, again, people with diverse experiences. We have clinical professionals, we have moms who serve on the board, we have males who serve on the board, and they give us such rich information about how to reach the community and the areas that we need to be focused on. So, I hope that, if nothing else, when I'm done, you are saying to yourself, I want to be involved in the MHREACH project. How many of you are thinking that? Raise your hand. Oh, a few. Okay, thank you, Dr. Szymanski, Dr. Estes. Okay, so what I want you to do is if you're involved, if you want to get involved, you put your phone on this QR code, and there are 3 ways to get involved. One is through our community engagement studios, where we will be recruiting people from the community to sit down and have discussions with researchers on campus on how to tailor their research methods to the community and disseminate their outcomes in culturally appropriate ways. We do have a community health worker training where we are sponsoring 4 individuals from the community. We will pay for them to go through a community health worker training here in town with the area health education centers. The classes start in January. It is all online. And again, we are sponsoring scholarships for 4 individuals from the community. If you know someone who's interested, please share the flyer that you can find in your folder. There's a flyer in your folder, and it talks about our program. Lastly, if you just want to get updates about resources and what's going on with MHREACH, please, again, share your information. And Kennedy Norwood is the person who will most likely be in touch with you, just letting you know when we have upcoming events like our maternal health conference that Dr. Ajawali is spearheading in January. We'll send you updates about other programs that we know about from other organizations as well. So I hope you'll take this opportunity to get involved. This is the community health worker flyer that you'll see in your folder. So again, please share it with someone in your community that might be interested in becoming a community health worker. And if you want to follow us, there's a way to do that as well. Ms. Norwood oversees our social media platforms as well. Thank you.
Thank you, Dr. Pounds. And also here's some of our photos from Kennedy's events where she goes off into the community, to the high schools, to make sure that we're engaged and getting people from various aspects of the Houston-Harris County area to be involved within maternal health. Next, we're going to have Dr. Ajewole speak about her MHREACH project. Dr. Veronica Ajewole Memwa is the director of the Research Infrastructure Corps here at MHREACH and the PI of the MHREACH project. She's also a professor at TSU and as a clinical pharmacist and adjunct assistant professor of oncology at Houston Methodist Hospital. She received her PharmD from TSU and completed her oncology pharmacy residency at Houston Methodist Hospital. She's a board-certified oncology pharmacist with clinical practice in oral chemotherapy at Houston Methodist Hospital Cancer Center. She's the founding director of the NIH MD-funded Community Engagement Corps at TSU CBMHR and TSU's iHeart. Dr. Ajewole.
Thank you very much, Cecilia, and good morning, everyone. How is everybody doing today? Full of energy? Was the breakfast great? I enjoyed it. Well, I would not be the person presenting today, but I would make way for our amazing fellow, recent graduate of Texas Southern University, recently fully licensed pharmacist, no other person but Jasmine Jones, who will be working alongside myself to implement this project. So please help me to welcome Jasmine as she runs over the presentation. Thank you.
Thank you, Dr. Ajewole. Okay. Good morning, everyone. I'm Jasmine Jones. I am the postdoc fellow in the MHREACH program in the College of Pharmacy under Dr. Ajewole and Dr. Poon. And I will be giving a presentation on our MHREACH project, which stands for Building an Innovative, Comprehensive, Multi-Level Medication Therapy Management Model Project. Very long title. We'll get into it. So this project is led by Dr. Veronica Ajewole, and I will be a pharmacist on this project, with the goal of creating a non-medical drivers of health-based MTM model, with non-medical drivers being non-medical factors that may positively or negatively influence the health of a patient. And then MTM services is something that a pharmacist, well, it stands for Medication Therapy Management, and it's a service that pharmacists offer to patients where they extensively look into the patient's medication or medical history to identify any medical or medication issues that could be, that could cause adverse effects in a patient. So whether that be identifying drug-drug interactions, toxicities, drug disease, and specifically with our project, since we are offering our MTM services to Black pregnant women in early to mid pregnancy and following them for a few months after postpartum, we will be identifying hopefully medications that may be potentially dangerous in mothers in certain stages of pregnancy or breastfeeding. So hopefully we can make those interventions as we see them before they become a bigger issue. This opportunity also gives us a chance to offer patient education and serve as like another intervention in between prenatal and postnatal care for patients to speak to a medical provider. And then we'll also be offering remote blood pressure monitoring in hopes to track blood pressure in patients and hopefully stop the possibility of preeclampsia or preeclampsia or eclampsia in these patients, as well as we'll offer social and nutritional support as needed for mothers we identify. So in order to accomplish our AIMS 2, which is the MTM model, we have to start with our AIMS 1, which is the identification of these non-medical drivers that these Black mothers may be facing, and then also proposing interventions that we can integrate into our AIMS 2. So we are accomplishing AIMS 1. We started a work group, which is like a think tank for community members who work in the maternal health space or have a strong passion for maternal health and creating better health outcomes for our Black mothers. And it's just a mixture of various people from various backgrounds in the maternal health space that work in our community. And we meet monthly, every second Saturday of the month, to just really tackle the issues at hand for our Black mothers. So the work group is entitled Voices of Pregnant and Parenting Work Group, and these are our members. As you can see, we have social workers, community health workers. We also have business owners as well, as we did have a mother on she was pregnant, but she recently had her baby, so she was also sitting in on the calls and providing feedback for us. So a little bit more about the AIMS-2, which is the non-medical drivers of health-based MTM model. So we're hoping to enroll pregnant women up to 24 weeks of pregnancy and then follow them for 64 weeks postpartum. And then offer our services to the MTM, as well as the remote blood pressure monitoring and the nutritional and social support. So just a little more into logistics. Black pregnant women, up to 24 weeks of pregnancy and then 64 weeks postpartum. To assess their non-medical drivers of health, at baseline, we're going to give them a prepared survey, which is just a survey already pre-made that's pretty widely used to determine the social determinants of health, non-medical drivers of health, and it goes over things like food insecurity, finances, housing insecurity, emotional. It's a pretty extensive list, but also condensed, so it's very user-friendly for our patients. We also will be recruiting patients through community clinics in Harris County, and then we'll be using the help of interns and community health workers to help us with the recruiting efforts. We will have a collaborative practice agreement, which basically gives the pharmacist permission to work on these patients under a provider at these clinics, and interventions, the remote blood pressure, the social nutritional support, and then the MTM service in itself. Time frame, we would like to do a feasibility study of just about 20 patients just to see if our model is working and any improvements we can make before we move a little more wide scale, with our first cohort being 125 patients with just the MTM, and then our second cohort being taking the non-medical drivers that we identified in AIMS-1 and then putting it into our MTM model to better serve our patients. And this is just a breakdown of time frame and enrollment. So we want to be doing like an intervention like every 6 weeks with the patient. And then we also, as we keep going, adding more patients to reach our goal of 250 patients. And that concludes the MHREACH program.
Thank you, Jasmine. Next, we're going to have Dr. Idowu come up here to talk about his MHAI MLPX project. Dr. Idowu serves as the PI for this project at MHREACH. He is also a research assistant professor here at Texas Southern University with expertise in molecular biology, biocomputational science, and artificial intelligence research. Through the TSU Leadership, Education, and Advancement in Undergraduate Research Pathways program, Dr. Idowu was appointed as a faculty member specializing in artificial intelligence and machine learning. He has provided TSU students with hands-on research opportunities, teaching them concepts and applications in data science, maternal and child health research, drug discovery, and more. Dr. Idowu.
Good morning, everyone. Thank you so much for the opportunity to present this. This is TSU, and one of the things we do in TSU is we roar against anything we don't like. Like last week, we roared against breast cancer. So this week, we are roaring against health disparity in maternal health. Welcome. So yeah, my project, I'm overseeing this project titled Understanding Trends and Disparity, Hypertensive Disorders of Pregnancy in Women. And I'm doing this together with my special ever versatile Cecilia. Yeah, so this project actually is going to be a secondary data analysis of natality data from US from the year 2022, 2023, 24, 25. So currently we are working on data from CDC natality from 2022 and 2023. Sorry. Okay, thank you. So we, like I said earlier, we're focusing on hypertensive disorder of pregnancy, and this includes hypertension, gestational hypertension, preeclampsia, and so on. And this data, like I've said earlier, we are focusing on secondary data. And under this project, we have three specific aims. And our first aim is to evaluate racial disparity and trend in HDP among women in US. And as we know, even though there is a common problem, but it is more distributed, to a certain race than the other. And the black women in African American are not really doing fine in that area. So the second objective is to develop a predictive model of HDP using SDOH data. So what that means is, looking at the trends, we can identify factors that contribute either negatively or positively to maternal outcome. So, for instance, if the zip code, for instance, is giving us a negative correlation, that means we can map that, this particular area, there is high prevalence of this. So when a patient shows up to the hospital, looking at all this data, feeding it into our model, it can predict the possible outcome for such a pregnant woman. And the third objective is to enhance maternal health data science education here in TSU. And how do we do this? We currently enroll our undergraduate students in programs, and we have a very big team taking this. And in my own area, I'm trying to teach the students the intersection between public health and data science, how you can use data techniques to analyze public health data and come up with a reasonable inference for that. So this training will encompass integrated data analysis, using of artificial intelligence algorithm in building model, and working that on data science, public health data. So this data I'm going to present today, we look at CDC data for 2022 birth natality, and this is data for 2022 with about over 2.5 million data from the US for that year. And after we did our data cleaning, removing repetition, we came up with a final of 2.4 million data. So these are the factors we look. We look at the mother's age, mother's education, the race, their cigarette before, during, and after pregnancy. And we look at their gestational diabetes, pre-gestational hypertension, and stuff like that. So this is a study looking at the trend and how this actually affects different races in US. So the data this first data is looking at the pre-pregnancy hypertension distribution among different races. And if you look at that point I put in in red box, we can see there is a significant increase in non-Hispanic non-Hispanic black. So which means even though it affects every races, but it is predominantly and significantly high as far as non-Hispanic black mother are concerned. And if you look at gestational hypertension, we can see a significant increase in gestational hypertension compared to the gestational hypertension. And in the field of molecular biology, we view pregnancy as oxidative stress. So that justifies the significant increase in the distribution of gestational hypertension compared to pre-gestational hypertension. And if you look at it intently, you can still see significant increase in non-Hispanic black and non-Hispanic African, Indian, and Atlantic native, right? So we also look at the distribution of pregnancy diabetes distribution, and we can see as well that this actually affects all races, but in this case, it's more prevalent in non-Hispanic, American Indian, and Atlantic native people. So when we look at the gestational diabetes in this case now, we can see significant increase in all races, but it's more pronounced more in the non-Hispanic IAN and non-Hispanic Asia. So now this actually gives us a kind of information. And what we did next is to look at the correlation between those factors that we've mentioned, gestational hypertension, pre-gestational hypertension, pre-pregnancy diabetes, and pregnancy diabetes, gestational diabetes, and looking at the correlation between that and maternal outcomes. And in this case, we try to look at what is the correlation between all those factors I've mentioned with maternal transfusion, placenta complication, admission to ICU, and the rest. And so And what we did was to do a kind of Partial correlation coefficient matrix to construct a correlation matrix to that. Now, and from this, we came up with a preliminary finding that shows that a strong correlation indicates maternal transfusion increase the likelihood of ICU. So when there is maternal transfusion, there is high possibility that such a patient will end up in ICU. And we also observed that when there is placenta complication, there is also a moderate positive, there is also a positive contribution that pre-existing and gestational hypertension contributes to that. So when there is pre-gestational hypertension, when there is gestational hypertension, there is likely for such a patient to come up with placenta complication. So because of time, so there is also a slight correlation between admission into ICU and uterus rupture. So when there is uterus rupture, there is high prevalence that such a patient will end up in the ICU. So stuff like that made us to come up with this conclusion that this study actually underscored the intricate relationship between maternal risk factors and medical complication. And significant correlation emphasized the importance of early and continuous monitoring of conditions such as pre-gestational diabetes, pre-existing hypertension, and eclampsia. So we are just trying to come up with an awareness for everybody to always, not even, I think in what we are trying to do in the bigger form is, everybody should be concerned about their diabetes and hypertension cases, even if they are not pregnant. So we're going to work on future research that is going to focus on uncovering the causal mechanism of this association and validate results in a large and more diverse cohort. So what we are trying to do, we are trying to not just to look at the OUS population, we are trying as much as possible to bring this to our own local community. So we are working currently to get data from Harris County and counties around us to do the same thing. Because this data actually, even though this data covers the whole of US, we can't specifically say which data is coming from Harris County or is coming from Greater Houston area. So we are trying as much as possible to get data from this area, local area, and do the same thing for these. I think that's all. Thank you so much for listening.
Thank you, Dr. Idowu. And now I'm going to welcome to the stage Dr. Ivy Poon. Dr. Poon is the director of the Investigator Development and Training Corps here at MHREACH. She is also a professor in the Pharmacy Practice and Administration Department here at our College of Pharmacy and Health Science at Texas Southern University. Dr. Poon received her Doctor of Pharmacy from the University of Houston and a Master of Science in Palliative Care from the University of Maryland at Baltimore. She is a licensed pharmacist and preceptor in the state of Texas and has served as a clinical pharmacy specialist and preceptor for pharmacy students at the Geriatrics Clinic in the Michael E. DeBakey VA Medical Center in Houston, Texas for more than 20 years. Dr. Poon.
Thank you. So I am over curriculum development and also training, and I serve as the core director for the Investigator Development and Training Corps. I've been at TSU for more than 20 years, and my passion is in teaching. And so when I first started out, being in the role for core director for Investigator Development and Training, then I started thinking about how can I create a curriculum that is reproducible and also can be used for our students, undergraduate, graduate, maybe postdoc, and all the way up to early stage investigator who are interested in maternal health disparity topics. So the first goal is to develop a maternal health disparity research course and a maternal health research mentorship program. So we have, for the past year, we have developed already, make a little bit progress in develop the first outline of the curriculum. It has lessons planned, and I do like pre and post assessment and try to see, how they feel about the topic. Is it more too difficult? Is it too easy? Is it adaptable? So far and so forth. So the first goal is to develop the curriculum and just to introduce it to them. When I first started with this project, one of the first things that I look around at my pharmacy school curriculum, I look left and right and ask, who teach this topic? Other than someone who come in and teach oral contraceptive or hormonal therapy, I really can't, identify a specific lecture that teach that to our pharmacy students. Just imagine that, One day they will become a pharmacist and they will be out there and filling prescription and serving the moms. And in their education is very science-based, drugs, side effects, all that stuff. And then so there is a need in this area so that they know our society, we have this problem out there. So they will be able to adapt to the need of the patients. So that is my main goal, develop the curriculum, and we will talk a little bit more about the curriculum in the next few slides. But aim 2 is to offer training and research mentorship. As Dr. Olayeye has introduced, we have postdocs, undergraduate, graduate students, and also early stage investigator. We want them to be interested and passionate in doing research in this topic. And we want to nurture them and promote their career growth in doing research in this topic. Number 3 is to evaluate the impact of the training. It's usually easy to develop a curriculum, but it's hard to go back and look at those evaluations and think about how can we improve in teaching them. What are the feedbacks? What do the students think? What does the mentee think? So number 3 is to evaluate our training curriculum. Now, so far, this past summer, and also right now, technically right now, we have 2 main training programs. The first one on the left-hand side is the undergraduate maternal health research program that is targeting at undergraduate students. And it starts in June 2024 and ends in March 2025. We have 4 undergraduate students in the program, and then they meet weekly to listen to lectures and do online learning modules. And then they are going to also involve in research in this area. Now, the one on the right-hand side is the flyer for that program. Yes. Now, this past summer, we had this wonderful opportunity that is funded by CareSource to, expand our reach to the high school student. This is a very new area for me. For the past 20 years, I have never taught high school students. I have 2 in my house, or I had 2. One is in college. But so I didn't know what to expect. Am I teaching too hard, too difficult? Do they understand it? So we developed a curriculum that includes 8 learning lessons, and they are all delivered by a platform called Nearpod. So essentially what it is we introduce 2 topics. There are 8 topics that we go through. What is maternal health disparities? What are the causes? What is social determinants of health? We talk about what are some strategies that has been proposed to tackle this problem. And then at the end, and also talk a little bit more about how do you do research, and what is a survey, what is an interview. At the end, we ask them to create an action plan as a high school student. Like, this is what I'm going to do. And I told them it could be very simple and very basic. It could be as basic as I'm going to do a food drive and donate some cans or food to a, women's program in my neighborhood, something like that. Or I'm going to start a club at my school. I gave them some examples, make it fun and easy so they can be part of the efforts to help and to learn more about it and inspire them. So one day they become, a professional in public health or in health professionals. So these are some examples of the graduate and undergraduate students' research. And then Before we go to the next segment, I want to show you that there is a flyer that is in the folder. This is an example of a research project that is being done by our high schooler, guided by us. So they're doing interview. If you are a student, faculty, community health worker, or any health professionals, if you are interested to be interviewed. So what we are trying to find out is we're trying to find the need for education and awareness about this topic. And so there is a QR code in here. I'm so proud of them. They designed the flyer. It's so pretty and pink. And anyone who is being interviewed will receive this very nice mug. Or no, is it called mug? A tumbler. Yeah, a tumbler. So it's very nice. So if you're interested, please scan the QR code. We are recruiting participants right now. Okay, so next. Okay, so next is the presentation of our collaborative stakeholders. So, let me see. Yes.
So we're going to do the quick maternal health key stakeholder collaborative presentations. I had sent out an email for some people to send in some slides. So I'm going to quickly show the slides are, and our two volunteers will hand a mic over to you. Let me bring this over. So for E2I2, there you go. It's like in the back. Yes, if you can get a mic to her, that way you can talk over your slides.
Thank you. Good morning. Well, it's a real pleasure to be here. I'm Louise Palmer. I'm the Executive Director of E2I2, the Environmental Equity Information Institute. We're an environmental justice nonprofit based in Atlanta, Georgia. We partner with communities to help them access, understand, and use data. And the use part is really important to our work. We really want to make sure that data, to democratize data and make sure that everybody can use it to expand their mission, to work towards their vision in their community. I'm also wearing two hats today. I'm representing Intellectual Concepts. E2I2 is IC's nonprofit, essentially, and Intellectual Concepts is a woman-owned engineering and professional services firm. They have a public health program pillar, and I serve as a public health subject matter expert for them. There is so much talent in this room today. I'm kind of starstruck by all of the work that you do. So we're just here to support, and if there's any additional expertise that we can offer to any of your teams, we'd be happy to do that. On the slide, you can see some of the areas that we might be able to support your teams. As I said, we have subject matter expertise in evidence-based best practices in maternal care models. I actually started my career working at the Royal College of Midwives in London. And so midwifery care is a really important component of maternal care to me. Also doula and community health worker models, super important. And then, it's essentially environmental injustice as a root cause of maternal morbidity and mortality. We all know that's a driver of the disparities that we're seeing, especially in Houston with the poor air quality and the extreme heat that you have here as well. We also have expertise in understanding, analyzing social and structural determinants of health. I know there's so many experts in the room here today on that also. In terms of skills, we are very much data-focused, whether that's collecting primary data, analyzing secondary data. So I know there's needs assessments, asset mapping, study design. It's all underway. You're doing amazing work, but we can contribute skills in that area also. In terms of we do a lot of data analytics. We develop data management systems. And then finally, the community-based project design. As I said, we work with communities to really partner at the community level to make sure that programs are responsive to their needs and their vision and their dreams. And so we're taking, from the classroom, what we know from academics and the research, and really translating that into meaningful community-based programs. And doing the evaluation piece of that, of course, is very important. And then finally, PMO, as they say, program management oversight. If there's any additional expertise or TA needs, that's something also that we can contribute to. So thank you all very much.
Thank you so much. Now, if a representative from Houston Health Department, raise their hand. There you go.
Good morning. My name is Ramatu Mansoure, and I'm here representing the Houston Health Department, and we have two of our team members here, Ms. Tolu and Ms. Nasheed. So some of the programs we have listed up there are our WIC, Nurse Family Partnership, Healthy Families, and of course we do offer family planning and reproductive health, and just some other programs that really focus on maternal child health. At the Houston Health Department, we are not primary care providers, and so we are more of a safety net provider. And so some of these programs fall into that space to where currently we're working to see how we can utilize and leverage some of those programs that we have to work with some of you guys in this room in a collaborative manner, and really just help us determine the impact that these programs are having and how we can better improve them. And so, of course, as you can see up there, our WIC program currently sees over 61,000 participants served every month. So it's very robust. Our family planning encounters are right up there as well, over 36,000, and we support over 150 families with our nurse home visitation programs, which is through the Nurse Family Partnership. Some of the things, as I mentioned, of course, is collaborating with you guys, our external stakeholders, to improve the use of the data, which is where Ms. Tolu and Nasheed fall in. Really trying to look at zip code level data. As some of you guys have mentioned, looking at that local data to drill it down so that we can impact the people around us. And of course, doing program evaluation to identify any areas of improvement that are needed. So looking forward to working with you guys. Thank you.
Thank you so much. Now we have our Maternal and Infant Environmental Health Riskscape Center.
Good morning, everybody. My name is Elaine Szymanski. I am a professor in the Center for Precision Environmental Health and Department of Medicine at Baylor College of Medicine. I direct a program in population and environmental health disparities, and I'm also the director of the Maternal and Infant Environmental Health Riskscape Center, or the MHREACH Center for short. We are one of 3 NIH-funded P50 Centers of Excellence on Environmental Health Disparities Research in the nation, and our goal is to identify factors in the built, physical, social, and biological environments that explain disparities, particularly black-white disparities in preterm birth and other perinatal health outcomes. And we approach our goal and achieve our goal through research, community engagement, and training and mentoring of the next generation of environmental health disparity researchers. We are a partnership among Baylor College of Medicine, the UT Health McGovern Medical School, as well as Texas Southern University. And I'd like to add that our community engagement efforts are led here by colleagues at TSU. Dr. King was instrumental in establishing our community advisory board, spearheading efforts in the first couple of years of our MHREACH Center, and Dr. Kim Pounds, who you heard from earlier, is now leading our community engagement and dissemination core and has sustained our community advisory board as well as expanded it, which is particularly important now that we're moving towards dissemination of our research findings. The center's research is primarily based on a cohort of pregnant persons, non-Hispanic Black, non-Hispanic white pregnant persons recruited around the time of delivery. We collect biological samples on these women to measure chemicals and biologic factors. We administer questionnaires which seek to gain information about social support and experiences of discrimination, as well as extract information from their electronic health records. And here our primary goal is in one of our studies to identify the independent and interacting effects of chemical and non-chemical stressors, again on preterm birth and other adverse perinatal outcomes. And in our second study, we're applying a machine learning approach to develop what we refer to as disparity-aware classifiers to identify the major predictors of preterm birth in our population. And I'll just then add that, or end with a comment about our Investigator Development Corps. We are focused on training the next generation of environmental health disparity researchers. We've trained 12 individuals thus far. These are scholars, both from Texas Southern University as well as from Baylor College of Medicine. And I think, as Dr. Lolai said earlier, we have to be invested in training the next generation of environmental health disparity researchers. And if indeed we do our job well, they will do more than we are doing, and they will continue to move the needle forward. So thank you very much.
Thank you so much. We now have UTMB Health with Dr. Vincent.
Hello. Wow, I'm blown away by all of the amazing people that you guys have brought together, Dr. Ajewale and Dr. Olaleye and your whole group here. So I'm Kathy Vincent. I'm an OB-GYN, and I primarily do research. I'm at UTMB. We're an academic medical center with the goals of patient care research and training, so it's really consistent with the goals of your project with the training and improving maternal health. We are engaged with Texas Southern University through our clinical and translational science award and our Institute for Translational Science. And so through that, we have a pilot project that we did that was addressing major causes of maternal mortality and disparities. I worked with some investigators here at Texas Southern University, and we had focus groups where we talked to about, well, I say we, the proverbial we, the Texas Southern University researchers talked to about 70 Black moms, and I found out concerns that they had, kind of walked them through their pregnancies, experiences they had, concerns they had, things they thought that providers could do better. They kind of collated their results, passed the baton to me. I talked to 27 OB providers and nurses, residents, fellows. We came up with some thoughts about how we could address those concerns, and then we went back, and then I got to talk to the moms too, so that was really a great experience for me. Together, we talked to about 15 Black moms again, and then we brought together the data from the initial group of moms and then the OB providers and nurses, and kind of talked through with them how we could provide ways for them to be supported through their pregnancies. And from that, we developed a couple of, there were actually 8 major areas where we could address that. And I was really happy to say that some residents and fellows got kind of motivated to action, and they were awarded a UTMB President's Cabinet Award for a 2-year project to do implementation of social determinants of health collecting that information and then acting on that to help patients, and then as well group prenatal care. So that just started a couple of months ago, and we're in the process of getting that organized and implemented. And that addresses about 3 of the concerns that the women had. And then we're working with a group at UTMB that has a substance use disorder clinic. We're working to get that with pregnant moms, because that was one of the major causes of maternal mortality, especially in the postpartum time period. And then also we're working with Department of Family Medicine with preconceptual care, because one of the things that came out of that was that, women come in already with chronic hypertension, diabetes that are not controlled, and so they're already pregnant. Can we help them get healthy before they get pregnant? So it really has launched several initiatives at our own university, and then we're also working with TSU. Just clinically, our labor and delivery had already done some things like drills for postpartum hemorrhage, drills for what happens if the baby gets stuck or if the cord prolapses, and things like that, that have been really, really helpful. Like, I kind of wish that they had it when I was in training. And so those kind of things that can ultimately be brought into the community, other labor and delivery centers that don't have the resources that we have for people to create and test these programs. And so I appreciate your time, and I'm excited to be part of this. So.
And finally, before we start our activity, a representative from Harris County Public Health.
Good morning. I'm Dr. Erica Brown. I'm the Division Director for Community Health and Wellness for Harris County Public Health and the Local Health Authority for Harris County. Before I get started, I do want to just introduce the team that we have that does all of this work that we'll get into. So to my left, we have Jennifer Kiger. She is the director of our epidemiology department. We have our new and exciting Healthy Start program manager, Michelle Harrell. Everybody already knows Lariana from Maternal Child Health. And then across the room, we also have Samara from our Black Maternal Health cohort for Access, and then we have Dawn, our lactation consultant, who transcends everybody everywhere to provide services across our programs. So just to get into a little bit of the programming that we have, it's very similar to Houston Health Department, but do want to clarify, because it gets confusing for everyone. They get our calls, we get their calls. You know, we're sisters, but we're not twins, okay? So Houston Health Department obviously serves the jurisdiction of Houston. Harris County Public Health serves unincorporated Harris County, and then the services that Houston Health Department does not provide, because Houston does sit in Harris County, Harris County Health Department does provide those services as well. As it pertains to some of our maternal child health programming, you will notice some overlap. So for instance, I'll start with the WIC program. Harris County Public Health also has a robust WIC program with 10 sites that serves unincorporated Harris County, whereas Houston serves, again, in Houston jurisdiction. As we just talked about, we were recently awarded the Healthy Start Initiative, so very excited. Yes, very excited to be ramping that up. I hope some of you will engage with us as we reach out to community partners to continue that work and push the needle forward in decreasing infant mortality, which of course cannot be affected without decreasing maternal mortality as well. The maternal mental health program, we also have, we were given, the term earmark is not the right term anymore, but that's really what it was. So we were very proud that we were given an earmark from Congresswoman Lizzie Fletcher to address maternal mental health, $1.4 million to address those issues that affect birthing persons. with their mental health needs, and we are continuing that work and growing that programming specifically with direct provision of care, and more so providing access through direct referral to those community resources and those who really have the infrastructure to provide care to those who are at high risk. Moving up a little bit, the clinical health services. As Houston stated, we are not a primary medical home, although it seems more and more we are standing in the gap and offering more and more services. We too offer reproductive health services. We also offer primary care prevention services addressing hypertension, diabetes, high cholesterol, and again, mental health as well. And it is, for whatever reason, unfortunate that we, in the largest medical center in the world, have a need to stand in the gap, not because our partners are not doing great work, but just because the demand far outweighs the capacity and the access that we currently have in this county. And so that's something that we really need to address. Our maternal child health program, again, everybody is very familiar with Lariana. She's done a phenomenal job over the last few years in launching this program. And I have to say, the branch off of Healthy Start came from her assistant manager, Michelle. So the two of them together is a dynamic duo. I will take credit. Thank you. But they've done phenomenal work. But the maternal child health program really is an intensive home visitation and care navigation program that aims to push moms towards self-sufficiency, to raise up a healthy family so that we can get a healthy child into a healthy start and off into the world. It can be up to a 3-year home visitation program and care navigation. We are in the process of being certified with Healthy Families America, which is very labor intensive. A program to support the home visitation, and very proud of that. And at this point, serving over 300 and something. Yeah, I know. You don't have to say that. Our goal was 150, but we're at 350 now. So y'all give her some. All righty. And then again, as I introduce Samar over there, I hope many of you know about our Access program. It is a very unique program called Accessing Coordinated Care and Empowering Self-Sufficiency, and the title speaks to it in a nutshell. And so one of the cohorts of our Access program is the Black maternal health cohort for obvious reasons. There are 5 cohorts now. There are 5 different cohorts that were chosen specifically around the vulnerable populations in the county who really need to be addressed, and Black mothers being one of them because of the high maternal mortality rate. And so we partner with them. They take more of the higher risk clients and give intensive care navigation and intensive case management. And then one of the great things about Access is Access has done great work over the last couple of years to contractually work with community partners around the data, so that there is one data hub where we can see from every partner, not just healthcare partners, but community partners, what is happening with that client, so we can get a holistic view and really address the social determinant needs of that client. So again, we can get them off to a great self-sufficient start. And then last but not least, we work with a lot of you in this room, the community partners, have taken some notes and put a plug in. We will have our 3rd annual Maternal Child Health Conference in April 11th and 12th. And so already got your names down. I'm sure you'll just be reaching out, because some of you, I think it would be great to provide some additional outlet for you all in terms of the great work that you all are doing. Hopefully, many of you have seen the Maternal Health Bill of Rights Z-Card. That is something that was born last year, which we felt was very, very important, because some of the work that we have done and the research that we have seen indicates that unfortunately birthing persons are not aware oftentimes of what their rights are, what's normal, what's not normal. And so we created a maternal health bill of rights that has a whole host of information from what is normal in the birthing journey. What do you have the right to? What questions should you be asking? What are your resources, either preterm and postpartum as well? And then just want to give a shout out again to our epidemiology team. There is a wonderful report on our website, and this QR code hopefully works and takes you to it as well. Our maternal and infant health report, which gives a state of the maternal health data for Harris County in the last, how many years? 5 years. And so obviously it's outdated the very next day, but it is as up to date as possible. I think it's 2023. Yeah, up to 2023. And so encourage you all to take a look at that. They have many other reports that also coincide. The chronic disease report is coming out. Substance use report are all on our website as well. And so there's some valuable information about the state of Harris County and how it is impacting our families. Thank you.
Thank you so much. And before we begin our collaborative discussion, if we could just get a group photo of everyone here. We want to make sure that we see everybody within maternal health represented here. So we're going to get a quick photo of everyone. Dr. Poon, if you'd like to come up, we're going to go ahead and begin our maternal health key stakeholder collaborative discussion. Grace will also be going around handing out some sticky notes to help out.
Okay, so I am being the moderator for this activity. We are going to have some active activity, which is fun, right? Instead of sitting and listening to speakers. So we're going to divide y'all into groups of 3 or 4. If you can just look around, find your neighbor, 3 or 4 per group. It is nice to get to know someone that you don't know to talk about. I mean, but we are not making you to, have to talk to a stranger. But if you are welcome to move your seats. If you would like to think about, hey, I want to meet a new person and work with a new person. So now, what are you going to discuss? See, we heard about all these wealth of expertise and activities and work that has been done so far. It is absolutely amazing. One of the things that we would like to see is more collaboration and teamwork, and think about how can we move the needle. And so we have 2 questions that we want you to think about. One is, what has been working well in your organization so far? Okay. The second question to discuss within the group is, how can you collaborate with TSU? Okay. Yes. So we have a board in here, and Dr. Olayeye had presented earlier about these are the main contributing factor for maternal mortality. That includes system of care, provider, facility-related, and community-related, and patient-family-related. Okay? So within your group, talk about what has been working well in your organization and how can you collaborate with TSU. And then there are some sticky notes in front of you. And what we would like to see is within your group, you discuss about it and you write down these ideas. Okay, how can you collaborate with TSU? And then we'll have some helpers. And because all these courts and stuff, so we'll have some helpers, and you can just tell the helpers that, please put that sticky note into system of care. And then, so whenever you're ready with a sticky note, then raise your hand. The helpers will come around and put it on the board, and then we'll have a discussion, a debrief. And it would be nice if one of you among the group will stand up and present what you have found. Are we clear? Yes? Okay. All right, so let's start. Give them like maybe 20, 10 minutes. 10 minutes. So talk fast. Ideas. Keep flowing.
And I didn't see Dawn. Okay. And then Samara.
Yeah, that's become my justice for MC. That's really good. I don't want to do How is everything? Everything is fine. I'm always relaxed. I just need hours to relax. Somebody was saying that. I said about this not a good work ethic. It's not a good work ethic.
All right, a little checkpoint. I don't see any note cards flowing out, so please start with popping these sticky notes out so we can discuss. Ooh, there's a lot of sticky notes over there. So once you have a sticky note, raise your hand and our helper will put it on the post board. Okay, you have 2 minutes left. 2 minutes.
That aren't going to be on the board, but just FYI. Yeah.
All right, time is up. Time is up. Okay, so let's go ahead and listen to some of the groups. And do we have any volunteer who would like to talk about what they have discussed? Any volunteer? Any volunteer? Group report? Okay, yay! We have a first volunteer. Yay!
You can keep yours.
Oh, keep mine. Okay, yes. Okay, everyone, listen up. So this first group is going to report on what they have discussed. Just tell us what you have discussed.
So I discussed how what works for me. Oh. Thank you. Sorry, I'm a little nervous. It's my first time at a speaking engagement. But my name is Olashe Adodo, and I'm here with the Osa Rosa Intervention Foundation. And we are an organization that helps women dealing with a condition called obstetric fistula. And this condition causes an involuntary leaking of urine and fecal waste. And it's prevalent in poor and rural communities, especially ones that have child marriage going on. So our foundation helps to give them the surgeries that they need to fix the leaking, and we also give them counseling so that they don't get in that position again and get the obstetric fistula again. And today we discussed what works for my foundation, and we found out that like funding and collaboration with small businesses have worked, and also like talking to local physicians has helped us. So yeah, thank you. This has been really helpful. Thank you.
All right.
The Osa Rosa Intervention Foundation.
Yeah, one of the ideas that I was talking to Cecilia was, is it possible that we can have a list of organizations who is here and kind of like create a contact list of some sort that we can share among the group? Yeah, that would be wonderful. Thank you. Thank you for your work. Thank you for sharing.
Okay, thank you so much. Yeah, I just wanted to say that I'm 17. I'm a teen founder. That's on the card. So if you...
Who still does?
Oh,
love it. Oh, I love it. Thank you.
Please let me know after if you want a card or anything. Thank you so much.
Thank you. Thank you. All right, any other groups? Yes.
Hello, everybody. My name is Brittany Short. I am a community affairs advisor with Harris County Precinct 1 Commissioner Rodney Ellis. So something that has worked well for us is multifaceted outreach and recruitment strategies, going out into the communities. I sit on a team of 6, and we each manage a region of Precinct 1. We broke it up into 6 different areas. So we go out into the community, engaging with stakeholders like this, or holding meetings within the community, providing, information about the access and resources that we have to offer. and answering the how can you collab with TSU question. Of course, everybody knows we have Commissioner's Court. So I think that MHREACH getting on the agenda and, and talking about, the opportunities that you provide and, how we can create policies to further this mission, I think would be really important.
Thank you so much. We're absolutely looking forward to it. Thank you. Thank you.
Hello, Ramatu from the Houston Health Department from the same group. We talked about what has worked well for us at the Houston Health Department. Even though we do not provide primary care and we're a safety net, we have different programs. We have like STD services, dental, family planning, and of course, WIC, Nurse Family Partnership, our maternal child health programs. And so generally what has worked well for us is if a client comes to any of those other services, we leverage those relationships and link them, refer them internally to some of those programs. And of course, if they need resources that we don't have internally, we link them to, either services that the county has or some of the services that some of you guys provide. So that has really worked out well for our clients and for us. And, really in looking at continuing how we can work with TSU and other programs is really linking in with all the services that everybody here provides for the clients and the community, because we will not be able to internally provide those services at all. But if we know that we can do a warm handoff and link them to services that they actually need, that would be a great way to leverage our resources.
Thank you. Thank you so much. Are there any other groups who would like to present? I heard a voice. Yeah.
Hi, I'm Felicia Latson with Swallace Advisory. Myself and Lance Rather work together to come up with and discuss basically how we work on two opposite ends of the spectrum that relate. Lance's work centers around AI and machine learning to gather population level data and then break that down back into blocks of data that's transcribable to smaller groups in the community. And on my end, where I can help support that work is by engaging directly with the community and helping community voice be elevated in the research process. And so while I'm focused on the individual voices, and then Lance's work can translate to gathering all of those voices and making it into data that can inform other decisions. So we're in systems of care and then community and patient family.
Thank you. I see a mixed model method in here. The voice and also the AI.
So we have Harris County, your group over here, Access and Lactation Consultant, and they provide that care in the in-between space of after the postpartum visit. Well, actually, it's like all throughout the time when, so maternal mortality actually is, throughout the whole pregnancy through a year after pregnancy. And what I've observed is that so there's a 1% mortality rate up to 42 days after pregnancy, but it goes up to 3% for the year after pregnancy. And they don't see OB-GYNs during that time. So I feel like it's really out of our hands and it's in your hands. And it's what you guys do that really is going to make the difference. And I'm like, can you come do this in Galveston County? To teach us what you're doing. So what they're doing, this is my observation of what they told us what they're doing, is they're going to see women and catching if they're depressed or if they're having issues, and they're able to bring that and provide that support. So I think that's huge. It answers the question of how they, I turned my page. But anyway, the first question of what's working is that you're establishing the support, which is what women told us in our pilot study that they really needed. Even if they're married or have pregnant friends, they need that support. Some things that we're doing at UTMB is we have 18 to 20 regional clinics that are in rural areas Crockett, where I grew up, Beaumont, Orange, New Caney, all areas outside of Harris County as well that where Harris County and Houston are not capturing, we're capturing the surrounding areas. So, and how we can collaborate, I'll let you guys talk about it. We can collaborate with clinics to help recruit patients with you guys. Also, we can work with you guys on future projects. This one is about hypertension and how it can contribute to cardiovascular disorders and maternal mortality, but you know, there's other causes, and we can work with you guys on projects related to that, and I'll let you guys talk about how y'all will work with them.
Good morning again, everyone. Just to kind of follow up with what Dr. Kathy said, what's working for us has definitely been the in-home visitation and being able to really follow our participants during pregnancy and after, assess them with their immediate needs, set their long-term goals, and of course, like she said, offering that actual in-person support, whether it be for breastfeeding. Our community healthcare workers are excellent, and they are thoroughly trained and educated on what to look out for. We collaborate a lot with March of Dimes. We were doing hypertensive kids, providing blood pressure monitoring in the homes with education, with things like that. So I would definitely echo that that is definitely an aspect. If it's not in your program, try to incorporate it, because that in-home physical presence makes a huge difference. Being able to pick up the phone and text or call your community healthcare worker or your lactation consultant makes all of the difference. And it makes them more receptive because we can meet them where they are. If they don't want us to come into the home, we'll meet them at Starbucks. We'll meet them at the library, wherever they're comfortable, just so that they can make sure that they're receiving that support. In regards to the second question, Samara and I and Dr. Kathy and Dr. Sharon were just talking about more collaboration, of course, with TSU. I know for lactation, barriers are the education and the awareness. And I think that's kind of across the board with maternal and child health, getting out there, getting engaged, partnering with you guys at different events, making a shift in the mindset of lactation and of going to see your OB-GYN and being enrolled in community resource programs that can help you. So those are the answers that we came up with.
Thank you so much. I agree 100% with what you said. Thank you.
Can I just say one more thing for Dawn? When Dawn went into LBJ Hospital, they had 2% breastfeeding rate when patients left the hospital, and her team, they had close to 90%.
90%,
Yeah.
whoa, from 2%, wow. Awesome. Wow, that's wonderful. We have time for one last group. Yes. Oh, the mic
thank you.
behind you, yes.
Wait a minute, I gotta put my glasses on. So under systems of care, there is great work happening, obviously, across our community. But one of the things that is not working is the sharing of data. The red tape and the barriers to sharing data, whether it be some statutory thing, whether it be just the contractual red tape that it takes to share data that really would help us push the needle forward in getting an understanding of what is happening in our community, and overlaying each one of our different sectors on top to get a full picture. Again, I think everybody is doing great work, but there is definitely a lens and perhaps a silo to it, not to anybody's fault, but again, because there's just so much barrier to sharing of the data, and I think that is really a system issue that needs to be addressed. The second thing that I'm putting my public health lens on is Harris County is one of the most diverse counties in the country. Even in terms of there are over 100 and something, almost 200 languages spoken in Harris County alone. The county itself is larger than some states in terms of its population and its size. For those of us who cover Harris County, it's a day to get from one end to the other. You may do two visits in a day on a good day, as long as there's not an accident or something on one of the highways. And that being said, it presents unique opportunity for all of us to consider, again, removing some of the barriers in all of these areas in terms of language, and in terms of access to care and understanding what that looks like and means for such a diverse culture and population. Public health is unique to have a refugee clinic in which the federal government allows us to provide screening services to refugees coming into the country. And I can tell you, in working with that clinic, the unique challenges of even the dialect of a language, the culture of a language that is different from ours here in the United States, and the lack of understanding and awareness of that, and sometimes, frankly, the offense to the patient without even knowing it, is a barrier. And so when we talk about not getting people engaged, we really have to think about something that, again, is unique to this community. It doesn't happen across the United States, and while we can take lesson from others in certain areas, there are very few other counties that experience the diversity that we have and have been able to crack the code to how do we engage everyone so that there is trust for them to engage with some of the resources that we have.
Thank you. Thank you so much. Thank you so much, everyone, for sharing. This is absolutely amazing to hear. So much work that yet to be done, and so much opportunity in front of us. We are run short in time, so we will move on to the next item on the agenda, and I'll give the mic back to Cecilia.
Yes, thank you again, everybody, for your participation in our collaborative discussion. I will now introduce our guest speaker for today. Lance Rather is a Senior Director of Product and Strategic Partnerships at PCCI, where he leverages his expertise in technology and data analytics to develop and refine health-related products. He plays a crucial role in the creation and enhancement of tools like the Community Vulnerability Compass, focusing on making complex data accessible and actionable for healthcare providers and policymakers. Lance's work ensures that PCCI's innovations are both user-friendly and impactful, driving better health outcomes and informed decision-making across various health systems and community-based initiatives. Please welcome Lance Rather.
Good morning, everyone. I'll be discussing today a little bit about PCCI as well as the work we do around our non-medical drivers of health, CVC, geospatial subdivisions, and prioritizing impact. And I actually met some of the individuals here today from our Healthier Texas Summit Conference, and they were kind enough to invite me, so thank you for that. And Dr. Brown, the words that you just said are actually a great segue into this, so I appreciate the transition. PCCI stands for Parkland Center for Clinical Innovation. We were originally a department of Parkland Health in Dallas County, the county hospital. We spun off as a 501(c) nonprofit organization, and what we are really prioritizing is impacting vulnerable populations in their health care. We do this through things like our AIM-Up-enabled digital technology and AI models, our AI for clinical decision support. These are things like our PTIM or trauma mortality model that runs in our trauma center, as well as our sepsis model. We also do AI for population health. This includes things like pediatric asthma, as well as preterm birth that we run for a health plan in Dallas County that has lowered costs by 20% and increased prenatal visits from 8 to 15%. But what we'll be talking about today is our non-medical drivers of health analytics that really we not only use as data itself, but also empowers our AI models. So we've heard it discussed a lot today, non-medical drivers of health, social determinants of health, and these are just merely refer to various conditions in the settings where individuals are born, reside, receive education, work, and engage in recreational activities. Now, we did frame this off the Healthy People 2030 framework that is on 5 pillars of economic stability, healthcare access and quality, neighborhood and built environment, social and community context, and education access, and quality. Now, we cover 4 of those pillars. We don't cover the social and community context through racism, discrimination, and incarceration due to those data sources being harder to acquire. But what we realized really quickly is non-medical drivers of health are all impacting healthcare, but you have to address certain ones before you can address others. If you have a family who's unable to pay for their rent, unable to pay for their food, the likelihood of them referring funds to preventative care and screenings is less likely. They need to take care of those base needs. Everyone remembers back to Maslow's hierarchy of needs from your intro to psychology class. Same principle with Warner's. We actually ran an accountable health communities within Dallas County utilizing CVC as our predetermining screening factors so that we would understand what we needed to screen patients on and their needs. What we realized is patients don't just have one need. If you have somebody coming in for utility assistance, they normally have a food insecurity, or they may have housing issues, or vehicle and transportation issues. What we saw is that individuals on average have 2.6 health-related social needs. So until we can start addressing non-medical drivers of health holistically for the individual, rather than in silos like Dr. Brown was mentioning, one at a time, we really can't create a system of change that's going to last. Instead, we're really working sometimes on addressing that need right then and there. So what we developed was our Community Vulnerability Compass. This was based on some of the shortcomings that we have from the Area Deprivation Index or the Social Vulnerability Index that you all may be familiar with, that really highlight vulnerability, but don't do as much to understanding what's driving that vulnerability and don't allow for really targeted intervention in a meaningful way. We built this on 4 pillars, from household essentials that are things like food insecurity, health insurance coverage, and household structure, to empowered people. That's being our connectivity, both smart devices and internet access, educational attainment, households without vehicles, literacy, and the walkability of that community. That's both sidewalks in the area as well as the distance to public transportation. And then we have equitable communities. That's things like affordable housing, clean air, green space access, neighborhood safety, neighborhood stability, and unemployment. And then good health that constitutes things like alcohol abuse, cancer, chronic diseases like asthma, COPD, kidney disease, and then life expectancy and mental health. So we wanted to help address the holistic person, really understand all of those 26 non-medical drivers of health and how they're impacting that individual. We did this through 9 statewide data sets that we have collected. I would love to say that we just got the data sets, put them together, and that was the end of our work. There's a lot of data science work that goes in behind this on imputation of missing values, as well as scaling and normalization. That way you can compare one non-medical driver of health to another. Obviously, in order to compare things like median income that may be $75,000 for a block group to a kidney disease rate that may be 3% for that block group, we have to scale and normalize that value so that you're able to compare those in a meaningful way to understand what of those vulnerabilities is most impacting that community. One thing that we do that's really unique is localizing that insight. So what we would do if we were talking about Harris County is we would create a denominator of just the zip codes, census tracts, and block groups in Harris County, and then we would do all of our data science work. My data scientists don't like this approach. It creates a lot more work for them. We have to redo this every time rather than doing it at state level. But what it means is you are understanding your population. I'm not picking on Central Texas, grew up there, but if we compare Harris County versus Central Texas, where I grew up in Lampasas County and cows outnumber people, it's not the same demographic that we're dealing with. They don't have the same issues. So we can take a particular county, we can remove zip codes from it if certain zip codes aren't serviced, all the way down to a block group, and tailor that data just for the community, just for the individual population, and just for those individuals you are serving, so that you can understand what's impacting them and really understand their voice. We do targeted indicators. So as I mentioned, we have 4 sub-indexes. Those are comprised of 26 non-medical drivers of health. We allow you to drill down into each one of those non-medical drivers of health in your community to see how each area's vulnerability differs for those as well as overall. That plays into our root cause analysis. And then better data. We curate all of our data. We make sure those values are imputed for block groups that may be missing based on an algorithm for closest neighbors. We also do all that scaling and normalization. We end up with 26 indicators, 5 indexes, over 23,000 unique geographies just for Texas, because you're talking about your block groups, your census tracts, zip codes. And we end up with over 700,000 unique vulnerability scores. Now, for anyone who's not aware, geographical breakouts, obviously we're all familiar with counties throughout Texas. Those get subdivided into zip codes. Zip codes are their own little bit of a headache. They don't divide evenly for any other geographical breakout, so you will have zip codes that fall within and without a county. Furthermore, you can break that out into a census tract, usually consisting of 1,200 to 8,000 people that further get divided to block groups, normally consisting of 600 to 3,000 individuals. Just keep in mind a block group is usually a few blocks together. So it really gives you greater insight on what's impacting that community. We don't have to look at a zip code anymore and try to address needs at a zip code level. Throughout Dallas County, you can drive through a zip code, and within the matter of a few blocks, you can go from areas that have a high vulnerability to more affluent areas that don't suffer from the same vulnerabilities for non-medical drivers of health. By addressing this at a block group level, you're able to understand where those vulnerabilities are. When you're doing targeted outreach, you are now able to pinpoint locations that need it more rather than trying to take the limited resources you have and spread them across the zip code, where the impact's going to be far less when you're not dealing with the areas that really need to be addressed in that zip code. You'll even note here, these are actual images from our Dallas County website. If you look at our census tract, the light green is very low vulnerability, and you have a census tract neighboring that that's a very high vulnerability. We have a census tract up in Addison that's with 2 census tracts within the same zip code. One is very low vulnerability, one is very high vulnerability. When you go to the very low vulnerability, across the board, very little vulnerabilities throughout. Everything's moderate or less. When you go to this, and it's predominantly white, Caucasian, with most of the individuals having bachelor's followed by master's degrees, while the census tract to the left, you are dealing with a higher Hispanic population followed by Black or African American, where it's tied for those without a high school degree and those with a high school degree or equivalent. And this is separated by a singular street, these 2 census tracts. So, what does this mean? As I mentioned, targeted resource allocation. Now we don't have to prioritize a zip code. We can break this down to a block group level. You can understand where those resources need to go in that community. Furthermore, like Dr. Brown was mentioning, cultural changes. You can understand what population you're dealing with. We're going to be introducing language into this so you have better cultural context, as well as understanding what your material needs to be. What language are you tailoring it to? You'll have educational levels so that you understand what written material needs to be written for what grade level. In addition, the interconnection of non-medical drivers of health. I know you all mentioned a mobile clinic earlier that you have now. Mobile clinics seem very easy to figure out where to deploy. Unfortunately, they're typically not. If you want to prioritize a zip code, the first thing you have to figure out is what block groups are kind of central for this zip code so that I can address the most individuals in the zip code. But then you have to look at health insurance coverage, which we cover, to understand, let me address the area that has the least amount of health insurance coverage, so I'm impacting the most people. Well, we can't put it up in an area that is not safe for individuals to go. So now we have to look at neighborhood safety. We need to find an area that has very low vulnerability for neighborhood safety. That way the individual patients are coming in, they feel safe in that parking lot that they're lining up. Additionally, your workers have to be safe in that area. We also need to see households without vehicles. We want to prioritize an area that has a high vulnerability for vehicles, because they're the ones who are less likely to be able to go in to their visits and actually get that health care. And finally, we also need to look at walkability. We need an area that has good public sidewalks, able to be accessed through public transportation and walkability. So that interconnection between non-medical drivers of health is very important to understand on how we select our outreach and how each of these impacts one another. Each one is either an input or an output of one. Additionally, what we can do is we can actually provide a proxy for non-medical drivers of health. What we've done for Parkland, as well as Dallas County Health and Human Services, is they provided us a list of individual addresses with a unique identifier. So we're talking about PII rather than PHI, and we are able to take those addresses and reverse geocode them, where we get the latitude and longitude for that address, and then we reverse geocode it back to a block group. And now they're able to utilize that block group information and key it back to all of the CVC data. So at a block group level, you are utilizing these 26 non-medical drivers of health for proxy for individuals you have never been able to screen, you don't have any of this information on, or maybe you've screened them 7 years ago. They were 18 at the time, they've now graduated college, they now have an income far beyond what they had, they've relocated to a new address, and they have a completely different set of barriers than they had before, so this gives a more accurate one than that outdated assessment as well. Now, this is a quick snippet of just what it looks like for proxy non-medical drivers of health. This is where we have attributed an address. In this case, it's actually University Health in San Antonio that we work with their transplant team. But we've attributed that address. You could search an address on the dashboard that we provide with this data. You can identify what block group information is impacting that individual that's sitting across from you, down from their overall vulnerability at that block group down to each of those 26 non-medical drivers of health. If you're having to do assessments, now you have a targeted way to know what should be impacting them based on where they live. You don't have to go through a full screening. This is typically how we did this in our AHC work, is utilized it in that way so that we would understand what may be impacting them, get a follow-up on that to ensure that was what was impacting them, and then provide resources for those needs.
You'll have to kind of turn to see it.
Not a problem. Which one is I'm blind?
So I think you're on the address right now.
Oh, thank you. I should just be able to. So, the other thing about data is it has to be accessible. If I give you a sheet filled with all of the block groups in Houston and 26 different indicators and vulnerability, understanding where that vulnerability is going to be very problematic. It starts to look like a lot like numbers, a lot like math. So what we did is break this out into a dashboard so that we can understand vulnerability through our catchment area. You will notice that the different colors are very low to very high. Anytime you see those are always talking about vulnerability. So even if it says literacy, very low is the vulnerability for literacy, very high is the vulnerability for literacy. As you'll see here, we predominantly have a very high vulnerability in Harris County towards the eastern zip codes. I don't think I'm shocking anyone with this information. Now, if we move over to census tract, though, you'll see that the colors start to be a little more disparate, and you'll see pockets throughout these where you will see vulnerability vary within a singular zip code. I was exploring this in the airport a little bit on the way here. Here, we have Jersey Village. We have an area with a very low vulnerability overall. If we select that, we can see the demographics here, predominantly white or Caucasian. We have bachelor's degree predominantly, followed by some college. But if we move over just a singular census tract, now we know that not everyone knows census tract numbers. They're 11 digits, impossible to remember. Same block groups are 12. So we do have a transparent map so that you can see cross streets, communicate it in that way. But now we have a very different population that we are dealing with, and very vulnerable population here. And we are literally just subdividing these by one street that separates these. If we want to get more information on this and really get a full snippet of what's impacting this, we can take this as well, copy this value. Like I said, these are 11 digits. I can't remember that off the top of my head. And we can move over to our individual geography report. And I'm looking at Census Tract right now, but we can go to block group as well. And now we have a full array of what is actually impacting the singular census tract or block group from all of those non-medical drivers of health. We can see from our good health, things like asthma, COPD, coronary heart disease, and kidney disease, very high in this community. Empowered people, education level is really what's impacting there. And then within household essentials, we have things related to health insurance coverage. Now, when we look at this in Dallas County, one of the interesting findings that we saw is when we went to cancer rates. If you're not familiar with Dallas County, southern Dallas County is the very vulnerable area of Dallas County, predominantly south of I-30. But when we look at cancer rates, we actually see an inverse of the vulnerability. We see northern Dallas, the more affluent areas, being flagged high vulnerability. This is self-reported data from CDC Places data, and the reason is the people in northern Dallas recognize that they have cancer much earlier. They're going in for screenings, they're going in for their yearly evaluations. Those in southern Dallas County are typically those that are going to go to Parkland Health as a county hospital, and they're not going in for cancer. They're going in because they have severe symptoms from their cancer, and they're going to the ED because they can't afford health care or those preventative screenings. And by the time it comes around to that CDC Places survey the next year, unfortunately, their prognosis has not been good. They caught it late stage. And that's why we see those very high vulnerabilities from our more affluent areas for cancer rates. Can you throw up the presentation for me? And really quickly, I'll walk through some of our use cases that we have been utilizing this for, just to give you a little more insight on how we've been able to apply this, what impacts it has had as well. So obviously this helps with prioritization. The first thing you have to do is evaluate vulnerability. We don't have to collect those data sets anymore. Now we have a one-place shop for that. And as Dr. Brown mentioned, right now collaborating is hard because of data. We all have a different language that we're speaking because of the data that we utilize at our organization. This at least gives you a starting point to utilize the same data as the other organizations within this community. A shared language so that you can discuss what those needs are, where those needs are at a block group level. You can better allocate those resources down to that block group level and really understand what those needs are. It's great to understand that there's an area of vulnerability, but you really need to know what is causing the vulnerability to address it. And then, like I said, collaboration. We've all had data sets that are disparate from one another. You get into a conversation of, well, where'd you get your data? Well, how relevant is your data? Do you have missing data in there? Are we not going to get a full view of this? And what have you done with the data after you downloaded it? So that breaks down all of those barriers so that you can have a shared language with one another in the community to really address these needs. Now, how have we used this? The State Health Agency, we actually work with Dallas County Health and Human Services. They're integrated with CVC along with Parkland Health. And what occurs is they utilize the dashboard for their outreach to better understand what communities they need to impact and what's impacting those communities. They utilize this for their collaboratives with CBOs, as well as some of their STA HIV prep as well. But additionally, they also utilize it when a patient calls them, they actually get a pop-up from their Salesforce. We've integrated directly to their Salesforce. When that patient calls in, it pings an API with their address, and we reverse geocode that on the spot for them, and they get a pop-up of all 26 non-medical drivers of health for that individual to know what is impacting that individual who is on the other end of the phone. CMS-funded program is our AHC program that we ran, in that we were referring other individuals to the resources of the community. It helped with understanding and addressing what needs may be impacting them without a full assessment. Public hospital, we work with Parkland Health, integrating it into Epic. They also utilize it for their Office of Talent Management to ensure equity across the zip codes that they serve. They have needs to employ from those CH&A zip codes in helping that community as well through employment. So they utilize it for that. They utilize it for their CH&A program and their pop health programs. The mental health, we actually worked with a mental health provider in Dallas County where they were trying to assess where to put affordable housing. And they had a few zip codes that they were looking at, and what we realized really quickly was we weren't just going to put this in the area that had the biggest need for housing because it wasn't a safe neighborhood. People weren't comfortable moving into this area. Additionally, most of these individuals who would be moving in here didn't have vehicles. So we had to also look at how walkable was that area. Was there public transportation in the area? So always multifaceted on the ways that we approach these things. Teaching hospitals, we work with a transplant organization, and we've paired this data with each of their individual patients so that we can understand equity across transplant donations, or recipients rather, as well as outcome measures based on non-medical drivers of health. Obviously, things like transplants are affected by more than just that clinical aspect, but also what environment are they going back to? Payer plans, as I mentioned, we work with some payer plans, and they utilize this for outreach and to also provide outreach for their patients to understand what's impacting them, to help provide better services to them, understanding if they have issues getting to those preventative screenings as well. And then we work with United Way of Dallas County in creating what we're calling the Data Capacity Building Initiative, where they're funding cohort creations, 2 per year, 12 to 15 organizations per year, and we are creating a learning modules for them where they walk through that, they get access to it so that they can collaboratively approach Dallas County and impacting research there. Thank you all. Questions? Anyone have any questions? Yeah, we do educational attainment, which is going to be grade level. That is going to be for anyone 25 years or over. That way we're not skewing it based on the younger population. And then we also do literacy. Literacy is at county level, but we do migrate it down to block group through just taking that score for the block groups. But we incorporate both those together since one is block group level and one's county. That way we can understand more at that block group level what's impacting it. Absolutely.
Thank you. This is so interesting, and I really think it's sort of the way that health systems need to be going. I also would like to talk a little bit about the limitations of the available data that you're using in your application and how you're planning to fill some of those data gaps. For example, the cancer example you gave is a really good example of, the data isn't always representative of what's happening on the ground. And I think, one of the things that's really important to do is always to ground truth the available data. So as community health workers go out, are there additional challenges or information that's on the ground that's not being represented in the available data? And we find that challenge a lot with climate and pollution health-related data, that it's just not really being collected at the local micro level. Mm-hmm. So, somebody could be sick because they're living right next to let's just say, a landfill, and so that's not necessarily in the database. So I guess a couple of questions would be, what are some of the limitations? How are you overcoming those? And then how can community health workers and other community-based health workers integrate their data into your system to kind of round it out and make it more holistic?
Yeah, absolutely. So the first thing is some of those data limitations are things like missing values from a particular block group. We use an algorithm to calculate that value based on the closest neighbors, approximating an average between the areas surrounding that. Additionally, some of the data refreshes for different data sources are at different times. So we do carry over some of the values if they're not refreshed every year. Most of our data is yearly refreshed, though. We find that most communities don't change over the course of a year, so that is a good approximation. We do have upcoming enhancements as well where we're looking to introduce access to vital services. I know that we have things like Find Help or 211 data in Texas, but we don't have a place to really centralize that vulnerability data with that access to vital services because we know that collaboration, every one of these CBOs really wants to collaborate, and it's very hard to understand what's all available to your patients. I know that we want to address every need, so we are introducing that. But CBOs are going to fill a niche that we can't. So we're going to address the what. We're addressing what is happening in that community at a data level. They have the boots on the ground. They will understand the why behind that. They're talking to these individuals each day. And one thing I didn't mention is one of the best things about this data is for nonprofit organizations or a lot of you, grant retrievals. You know, we spend a lot of time on getting grants, allocating those and getting them and making a compelling story for those grants. And the story is very easy from a patient level, and talking about, you know, a single mother that is across from you with 5 kids and has a need for health care that she can't afford. But the harder part is really driving that story home with data. And so this provides a way for CBOs and other partners in the community to really have data for that data-driven storytelling for grant, for funding, and for policy making as well. Thank you very much. Oh, yeah. And one random note while she passes you the mic, the other thing that we utilize all this non-medical drivers of health for is also on our predictive models. While we have clinical data from Parkland when we do predictive models for them, we do find that usually 1, 2, or 3 of these non-medical drivers of health make it into our predictive models because they work in collaboration with that clinical data better than other clinical data.
Yeah, this is amazing. Thank you so much for this, really insightful presentation. My question is looking at the link between geocoded data, geospatial data like you shared, and individual level data. And I'll give an example. For a disease like cancer, where we know that exposure is longitudinal, right? And if you are trying to associate cancer development with environmental exposure or what someone has been through over the life course history of their social determinant of health exposure, is there a way to quantify that, within this data? Because with geocoded information, you are looking at the physical location, but we humans, we relocate. There are some people that have been in a particular address for maybe 20, 30 years, but that is not for everybody. So how then, is there a way to bridge that gap in between relocation and what someone has been exposed to over their lifetime?
So that's a great question. We don't have individual level data. I wish we did. We're all striving for that. But what we can do is we can incorporate this into predictive models. We have a predictive model that we run in coordination with Dallas County Health and Human Services as well as Parkland Hospital. It's called PASS, which is our Pediatric Asthma Surveillance System. And what it does is it takes ED visits from pediatric patients that come in for asthma-related ED visits, and it predicts what census tracts they're more likely to come from due to some of those components. And we utilize that based on a couple non-medical drivers of health as well as clinical data to really evaluate who is more likely, what block groups are more likely to come in, so that the CHNA group can do more outreach in those areas. And the same thing would be true with environmental. If you could do a predictive factor where you saw higher cancer rates maybe due to waste fill or lead, then you could do outreach in that way. Thank you.
We have one more question over here, but just FYI, if anyone needs to take a bathroom break, the women's bathroom is over there on the right side of the building. The men's restroom is over on the left side of the building. Now would be a good time to go ahead and go. We're going to have one more question asked, and then we're going to move on to our keynote speaker.
Thank you, Lance, for the wonderful presentation. And it's really informative to know about that tool. I wanted to know, if this tool is available for use.
So we are a nonprofit, so it is a commercial product that we do sell licenses to. And if you have an interest in that for your organization, definitely speak with us and we can talk about that. But we do have to support it. There is paid data sources in here that we have to do upkeep on, as well as the data science work that we do every year.
Okay, wonderful. And my second part of the question is, how up to date is the data? You mentioned one of the sources, CDC Place.
Mm-hmm.
So how much up to date is the data?
Absolutely. CDC Places should be a yearly refresh. ACS is a yearly refresh. Then we have AGS Crime Risk, which is 6 months every refresh. Open Weather is a monthly ping on an API. So most of these are going to be at least yearly. There are a couple that lag behind, though.
Okay, thank you.
Absolutely.
Thank you once again for your presentation. It was very insightful. We love it. We're now going to move on to our keynote speaker, Dr. Sherry Onyego. She serves as the Texas Medical Director for Value-Based Care Leader, Equality Health, where she engages and supports primary care practices across the state to advance value-based care models to patient populations with socioeconomic barriers. Prior to this role, Dr. Onyego was part of the executive leadership team within Harris County Public Health, serving as the Director for Nutrition and Chronic Disease Prevention. Dr. Onyego is a board-certified family physician with over 15 years of clinical experience in managing and treating chronic diseases as it relates to individual patient care and population health. Dr. Onyego earned a doctorate in pharmacology from Meharry Medical College and attended medical school at Ross University School of Medicine and continued her residency training in family medicine at Louisiana State. We now welcome Dr. Sherry Onyego.
Thank you so much. Appreciate the introduction, and thank you so much for the time to be able to present to you all. I'm going to try my best to stick to this time because I know you all on a tight schedule, and I don't want to be the one standing between you and lunch. But I was really happy to have the opportunity to connect with the team recently in Austin at the Texas Healthier Summit, where we had a panel on maternal health. And so certainly am and always happy to share with as many stakeholders as possible about the work that we're doing at the state level, because it really is reflective of the women across the state who've been impacted by morbidity and mortality associated with pregnancy. So I'll provide to you today just a little bit of insights from our most recent biannual report. Every other year, the Texas Maternal Mortality and Morbidity Review Committee, we put forth recommendations, and we also inform the public on the findings that we were able to delineate and glean from the cohort of women cases that we've reviewed for that time period. And so this past September, we released the report that allowed for us to be able to share with the broader community the work that went into us reviewing close to 200 cases of women who passed away and who died during pregnancy or the 12 months postpartum, and we basically walked those cases back as a committee. And so, in essence, we're sharing with you the results of those findings, and as well as putting forth recommendations. And so, essentially, how many of you all have heard about the Maternal Mortality Morbidity Review Committee? Great. So I don't have to spend a lot of time on this. But at any rate, just a quick high level, we are pretty much a multidisciplinary group of individuals who are really representative across the entire state of Texas. We come from different backgrounds, really looking at ways that we can come together, look at cases, and then with these unique perspectives that we have as a committee, we're able to really dive in deep, as I mentioned, and walk back each one of these cases. And it's really interesting because I've been on the committee for a number of years, but really have had an opportunity to engage with colleagues who are also on the committee and really look at their perspective as well when we're talking about this work. It's really, and I always tell people it's really meaningful and rewarding work, but it's difficult work because you're also honoring the lives of these women, and we know that these are families that have been impacted by the loss of a mother, of a daughter, and friends, and so we really don't take this work lightly. But at a high level, we're charged as a review committee to ultimately study these cases. We look for pregnancy-related deaths. We also look at different trends and look at different rates, and also we highlight the disparities that continue to persist amongst our state as it relates to these deaths. We also determine the feasibility of these cases by looking at severe maternal mortality, and I'll tell you a little bit more about that. And then we also are charged with consulting with our other stakeholders. One of our important stakeholders across the state is our Perinatal Advisory Council, and we also, again, in addition to that, to the Perinatal Advisory Council, or the PAC, we're also very interested in continuing to amplify the report to important stakeholders such as you all around the table. So I'll just dive in real deep and then just really sort of center the presentation around these 4 key questions. One of the questions that we ultimately look at is, was the death related to pregnancy? And that's a complicated question. When we look at these cases, we have to look at any element that really sticks out in order for us to be able to say, yes, we know with certainty and we know with confidence that this death was ultimately related to death. Sometimes it's not as clear cut. We're working sometimes with the information that we have in front of us. And then I'll tell you a little bit more about this as we go on to the presentation. Oftentimes we may have limited records. Oftentimes we may have more comprehensive records. Autopsy records are extremely critical and vital, but we know that that's not always something that happens. And then we also look at additional key questions such as what were the contributors and what were the causes of death. And as we go through this 2020 cohort, we'll highlight those. And then one of the important factors that we often talk about is if we know that this was a pregnancy-related death, then was that death preventable? And what we've continued to see each report is that 80 to 90% of these deaths, unfortunately, that happen during pregnancy are preventable if they're related to pregnancy. And then the ultimate key questions that we look at, and we really take it very importantly, is that each time we're pushing out a report every other year, we want to make sure that those recommendations are insightful and impactful of the findings that we've been able to highlight. So I'll just jump right in, and I'll, again, try to keep my eye on the time. But I have a link to the report as well, and that'll be shared with the attendees. So the first finding really does sort of articulate the pregnancy-associated deaths from our 2020 cohort. We know that about 42% of the deaths were all pregnancy-related, with the greater majority of those being pregnancy associated, but when we reviewed those cases, we really we could not determine if they were actually related to the cases. But definitely from the 2020 cohort, we know that about 42% of those deaths were ultimately pregnancy related. And as I mentioned, when we carve out those 42% of those cases that were pregnancy related, 80% of those were preventable. So what does that mean? That means that we could have impacted the lives of those women either during that pregnancy course or sometime during that postpartum course, whether it was related to the management of care that she received, the access of care, a number of factors are all related to that. But this is, again, something that we have continued to see, not just with the work that Texas Morbidity and Mortality Review Committee is seeing, but we're seeing this trend across the country. And then when we look at the ultimate causes of death, for this 2020 cohort, 6 leading causes of death were the priority reasons as to what contributed to these deaths. Those 6 included infections, and to a large degree, those infections were related to COVID, as we know during that 2020 time course. I have some shared colleagues in the room with me who we know very well the major impact that COVID had on our community, and pregnant women were not spared by this. Cardiovascular conditions came in second as an additional leading cause, followed by OB hemorrhage, embolisms, cardiovascular, cerebral vascular accidents such as strokes, as well as mental health conditions. I will point out that in our previous reports and from our previous leading causes of death, mental health conditions were a higher leading cause of death, and we've seen in this 2020 cohort that it has fallen, but I think that that's certainly not to say that we still don't need the resources, we still don't need the additional services to address mental health conditions, because we still see it as a leading cause. Just diving in deeper to tell you a little bit more about some of these infection-related causes. As I mentioned, COVID-19 was certainly the lead infection that was related to these deaths, but also sepsis, genital infections, as well as non-pelvic infections were also high drivers. And then when we looked at these cardiovascular conditions, the aneurysms, hypertensive cardiovascular disease, as well as arrhythmias, other cardiovascular conditions, as well as congenital conditions were also high drivers. So we know that there's a great number of these women that we've looked at in these cohorts, as well as previous cohorts, who have long-standing chronic hypertension. And certainly I know that the work that you all are discussing today will be really looking at interventions to address that as well. Then I just wanted to point out a few other salient points around violence. And so what we know too, unfortunately, is that we continue to see intimate partner violence as a driver that's really impacting women in these, as it relates to these pregnancy-related deaths. We know that violent pregnancy-related deaths with the manner of death inclusive of suicide or homicide represents a little less than 10% of the cases in this cohort. As I mentioned, intimate partner violence continues to be one of those drivers, and the most frequent means when it is something related to intimate partner violence or domestic violence has included firearms, overdose, falls, airway constriction related to strangulation, and sharp instruments. And so I can just tell you, just from sitting on the committee for a number of years and having to review some of these cases, it's very difficult to sort of see and read through some of the traumatic deaths that some of these women have had to go through when it comes to these violent deaths. So still a lot for us to do in terms of intervening when we can and when we have women in our community, in our systems. And additionally, obesity contributed to about 26% of the pregnancy-related deaths, so still a key driver. As I mentioned, mental health disorders, aside from substance use disorders, also, even though it fell to the 6th position in this 2020 cohort, it's still driving around 8% of those pregnancy-related deaths. And then when we dive in deeper around substance use disorder, opioid use disorder, those kinds of things, it's contributing to about 7% of the pregnancy-related deaths. And then when we wanted to also provide additional information about those additional barriers to care, we typically will also look for any insight within those cases that also tell the story. Were there access to care barriers? Was there language accommodations made for this woman when she entered care? Did she experience bias, implicit bias, stigma because she had a history of substance use disorder? We look for all of those things, then that helps us to be able to continue to really sort of tell a more comprehensive story about additional barriers or factors that contributed to that death. And so these are some of the complex interactions and factors that we've been continuing to track over the course of several years. You'll see here, when we look at those factors, whether it's access to care, whether it's bias, we look at it across multiple different continuums. That includes the systems of care. It includes factors that a woman may have experienced at the provider level, at the facility. Was she at a facility that did not have that didn't have specific types of services to address her condition? Was it community-based interventions or systems? Was she in a safe community that also did not have resources for her to be able to have a healthy pregnancy and postpartum period? And were there factors impacting the patient herself or the family? And so, again, these are just sort of the domains that we're also looking at as we're reviewing these individual cases. And so, in essence, when we look at the pregnancy-related mortality ratios, this is really more of an instance where we're really diving in deep to try to look at what's happening across the race, ethnicity, age, socioeconomic status. And so, compared to the 2019 cohort, what we've seen is that the Texas pregnancy-related mortality ratio increased. We've also seen, unfortunately, that disparities are continuing to persist. We're continuing to see African American women be impacted by morbidity and mortality at 2, sometimes 3 times the rate of other women the same age. And then we're also seeing older women and women with a high school education or less also be more impacted. And so this just really articulates that. And so when you see this is basically looking at the data from the women from the entire cohort, non-Hispanic white women, non-Hispanic Black women, Hispanics, and non-Hispanic other. And I'll just call out attention here to the non-Hispanic Black women. You'll see here that their pregnancy-related mortality ratio is significantly higher when you compare it to Hispanic, non-Hispanic other, non-Hispanic white, and as I mentioned, sometimes at a rate 2 times fold. So continuing to see those health disparities exist amongst minority women. Again, when you look at it by the age breakdown, we're continuing to see that women with advanced maternal age, women with advanced maternal age, significantly higher pregnancy-related mortality ratios. And then when you look at the education breakdown, so when you look at women with less than high school, college and college graduates, you're seeing here the higher propensity of that pregnancy-related ratio with women with a high school or less level education. This, I'm not going to spend a whole lot of time because I do want to spend some time getting to the recommendations, because I think that's really where where we have some opportunity to collaborate and further discuss. This just really speaks to some of those factors that we were discussing earlier. We were looking at preventability here, looking at preventability for the underlying cause of death across each of the years. So this takes us back from the 2019 cohort to the 2020 cohort, looking at the preventable deaths versus those that were non-preventable. I think it's just really just to articulate and speak to the fact that we have a number of these pregnancy-related deaths. So many of them are preventable. This is also looking at the timing of death. Again, across all of those across the 2019 and 2020 cohort, and we're looking at the timing and then also timing based on pregnant at the time of death, looking at it from a 42 days and then 43 to a year from a timing perspective. Similar data, but we're just looking at it across race and ethnicity. And again, highlighting those top causes inclusive of infection, hemorrhage, mental health conditions, embolisms, and cardiovascular conditions. And then this is just looking at the location of death, highlighting here one of obviously the big thing to point out here is that for these mental health conditions, the vast majority of those are happening outside of the hospital and in our communities. And when we look at the complex interplay of those factors related to preventable pregnancy-related deaths, this is just looking at it across the race and ethnicity. Similar data here, we're just looking at the interplay of those factors across the conditions, and then also looking at it from the systems, facility, community, and at the patient level. So apologies that I had to run through that, but again, like I mentioned, the link for the report will be included in the slides, but I really wanted to make sure that we had time to talk about the recommendations that the committee has put forth. And so recommendations 1 and 11 really is geared at looking at access to care. And so again, what we've continued to see with these deaths in each cohort that we look at, we continue to tease out access being a really big issue. We know that there's, across the state, there's a number of women who present late to prenatal care. Medicaid covers about 50% of the women in our state. And so we know that access to timely Medicaid coverage and other coverage is a big issue, and it really impacts how timely women actually present to care. And for a number of years, we've continued to discuss at the level of the committee that we think it's important for women to have access throughout the life course. We're very grateful and really appreciative of all the advocacy and all of the legislative work that went into House Bill 12 getting passed. We will, this is another recommendation, we'll certainly be looking at the impacts that the trends will play out now that HB 12 has been implemented. We hope to see a decrease in some of these numbers. But again, I think it's imperative. I think it's needed. I think we, obviously, adequate care beyond, for an additional 12 months was something that we desperately needed to do. I always say necessary, sufficient, but possibly not enough. Well, we know it's not enough. So this really speaks to just really women having full course, that whole life course of access to care. And so, that obviously is inclusive of preconception, pregnancy, postpartum, interpregnancy, fourth trimester, however you want to, sort of delineate it. It's really throughout multiple periods of that woman's lifespan, and we know that that's really where the impact can be made by ensuring that true continuity of care and instead of fragmented care. I think when we have a lot of these conversations about maternal health, we're really looking at a woman, from the waist below, and we really have to look at all aspects of that woman throughout multiple periods of her life. And so recommendation number 11, really, again, I was so excited to be a part of this discussion because it really ties into recommendation number 11, which really talks about continuing to prioritize education, diversification of our workforce, increasing maternal health workforce capacity, and it really ties into all of the work that you all are doing, because we know that some of these factors that interplay or that we've teased out when we're looking at these individual cases, we know that our state is broad, it's diverse, and we want to make sure that our workforce is representative of the demographics and of the community that we live in. We know there's a lot of studies that certainly substantiate the fact that women and individuals feel more comfortable when they are receiving health care from individuals that look like them, that sound like them, that can relate to them. And so I think it's imperative that we continue to prioritize the future leaders who are going to be stepping into this space. Recommendations number 2 really does look at our public health emergencies and inclusion of pregnant women as a high-risk group. And really this recommendation came about because in 2020, because of the impacts of COVID, we continue to see so many of the deaths that were related to COVID. We were able, at the committee, we were able to formulate a timeline, to really look at, as we were reviewing the cases, we were able to go back to the timeline and look at, okay, well, when were the vaccines made available? Or when were the therapeutics made available? And so by us being able to look at things like that, we were able to also continue to, unfortunately, tease out gaps and see where pregnant women weren't necessarily factored into those high-risk groups. And so this really speaks to recommendation 2, which really does speak to ensuring that we're prioritizing the resources and the treatments and making sure that pregnant women are included in those recommendations as we know that we're going to enter into another public health emergency at some point in the future. And then 3, 4, and 5 recommendation really does speak to safety and equity. And this is really, again, I think that the collective brains across the table in this room really does also have a stake in this as well, because we really think it's important, because we've continued to see Black women have 2 to 3 times the pregnancy-related mortality. We want to make sure that Black communities are engaged. We want to make sure that they're addressing these health disparities as well, and whether that's community-based programs, doing these types of collaboratives where a number of stakeholders are coming across, multiple different sectors to really impact this. And so at the committee level, we want to make sure that as many stakeholders as possible, that we can amplify the work that you all are doing, because we want to make sure that these communities know where the resources are. And then recommendation 4 really does look at ways that we can continue to amplify provider awareness, and also make sure that providers are participating in some of these statewide health and safety initiatives. And so for a number of years, we've been able to implement a number of the safety AIM bundles across many Texas hospitals. And so that we've seen, with the implementation of those safety bundles, we've seen a decrease in things like OB hemorrhage. We've recently rolled out the maternal safety bundle for substance use disorder. So hopefully, again, that will see an impact in those. But we really want to make sure that providers are aware. We want to make sure that more hospitals are engaged in those types of safety programs as well. Recommendation 5 really does hinge on public awareness, community engagement, all the things that you all are doing right now. One of the things that we've continued to also amplify is the CDC has the Hear Her campaign. Texas has adopted their version of the Hear Her campaign. All of those materials, social media collateral, print collateral for your facilities, all of that's available on the Department of State Health Services website. And I certainly can also make sure that you all have access to that as well. And then recommendation 6 really does lead to the discussion around behavioral health. And so we want to really make sure that even though we saw mental health pregnancy-related deaths decline, we still recognize it as still one of the leading causes. And so that being said, really it's important to make sure that we have some integrated behavioral health supports across the continuum. We've continued to try to amplify the work that the PERIPAN, the Perinatal Psychiatry Access Network, is doing across the state. We know that they started off as a pilot, but now they have expanded their work, and so certainly healthcare providers, different agencies can certainly tap into that as a vehicle for addressing some of these issues as they come across patients in their health settings. And then 7 and 8 really deals with violence. And so really this talks about improving the infrastructure and really looking at programs to address violence. Again, as I mentioned, we're continuing to see intimate partner violence as a causative driver for some of these deaths. And so really it's sort of certainly not lost on the healthcare institutions, but really the broader community that's engaging with these women to really sort of be able to to ensure that they have safe spaces and really have an opportunity to get the resources that they need if they're in a situation that ultimately can impact their lives. And then also fostering these safe and supportive community environments. And so again, making sure our community-based organizations know where their supports and where their resources are to be able to appropriately address these women when they're coming to them for various services. 9 and 10 really does look at emergency care and care coordination, and that really does look at, it really does go back to the fact that over the years that we've been doing these reports, we continue to see that women have a touch point with emergency care services, and so it's important that we support those emergency care services with the important resources to know what to do when they're engaging with women during pregnancy or postpartum, really making sure that they understand what are those early warning signs, what are those red flag things that they should be looking out for. And I think that even goes into something as important as what facility are you going to transport this woman to? Because again, we continue to see cases where a woman may get transported to a facility that doesn't even have the ability to fully address the needs of that woman. So we really want to make sure that we're supporting our emergency management services, that we're working across the continuum to really help them as well. And then care coordination is a really important piece. We continue to see, again, those non-medical drivers that were discussed earlier, housing, safe supports around transportation. We want to make sure that case management, social workers, that they're engaging appropriately to really do the adequate care coordination that's needed when engaging with women from the community. And ultimately, the last recommendation that we have put forth, and that we've put this recommendation forth for a number of years, and that's really for us to, as a committee, to continue to support the work that we're doing by looking at ways that we can continue to strive for quality improvement, process improvement, to really make sure that we're efficiently and adequately addressing and evaluating these cases. Most recently, in this past legislative session, we did put forth, there was some legislation that was put forth for the redaction process to be removed. And the redaction process really is a process that's put in place to really sort of, obviously, to remove any identifying information from the individual cases. That being said, it also cuts into the time that it takes for us to really review and process and evaluate these cases. Ultimately, that legislation did not make it across the finish line, but we're hopeful in this upcoming session that we will be able to get some rewarding and impactful legislation across. We were able to increase the capacity of the committee, so we have more diverse voices. We've introduced emergency medicine to the committee. We've introduced cardiology as well as pathology to the committee. So we're really excited, as well as managed care representation. So we're continuing to look at ways to ensure that we're holding ourselves accountable to you all in the community to make sure we're doing the appropriate justice with these case reviews. And so then wanted to just, before I close, just kind of highlight opportunities as it relates to what we can continue to do as a committee to support our stakeholders. And so certainly wanted to just highlight a few of those. Obviously, you know, I think I said it earlier when we talked about recommendation number 11, that really does talk about increasing the maternal health workforce. And then also, as we look at opportunities to increase the maternal health workforce, there are other things that you can really sort of drill down to, things like team-based clinical simulations. I think that a lot of the information and the insights that's gleaned from the findings, as well as from the recommendation, can be integrated into curriculums, into case-based simulations, to really ensure that learners understand and can appropriately respond to pregnant women when they're engaging with them. And then also, as I mentioned earlier, I think we really want to make sure that we talk to as many stakeholders as possible about supporting the Hear Her campaign. I think that's a great way to amplify not only the voice of moms, but it's also a way to ensure that families and communities, that they're all understanding that it's important and imperative to listen to women when they are when they're voicing their concerns, that we all really recognize what are those early warning signs, and a lot of that insight is teased out in this Hear Her campaign. So certainly wanted to call attention to that. And then just wanted to highlight the work that's not only happening here at TSU, but also another HBCU, Houston Tellison, that's they're doing some really fantastic work with Blue Cross Blue Shield in their Boldly Blue project, and they're really looking to train community health workers, doulas, really over the course of 8 to 12 months. And really that's a way that they're really trying to pour into their community and increase the maternal health workforce. So I will pause there. It looks like I'm 3 minutes over, but I'll be happy to take any questions. And this is a link to the full report.
Yes. On behalf of TSU MHREACH, we just wanted to give you a gift for our appreciation for being our keynote speaker today. Thank you. Any questions? All good? All good. Any questions or? Good? I think. Thank you so much again. All right. And almost to everybody's favorite time, we're going to begin our lunch break pretty soon. Again, just reminder that to be mindful of the walls and the artwork that is on our museum walls. We'd also like to take one more group photo, but with everyone standing next to each other, just right next to this back table. And then as soon as we take our photo, everyone will already be up to take their lunch. So if everyone wouldn't mind getting up to take our photo right at the back, that way we can have a nice, pretty background as well. And then we'll begin our lunch segment. Thank you. Thank you, thank you. Make sure you gather around more towards the center. Yes. Anyone that's short can be right up front. Dr. Pounds, photo. Everyone. Yes. Also, yes, any community members here as well. Yes. Just any stakeholder, community members that are here right now. you again, everybody, for the photo. Just a reminder, our lunch is being served right here on the left side wing. You can pick up your plates. We have fish, oxtail, and tofu options for everybody. Sides are as well. All the drinks are going to be on the right side wing. We're going to have about 20 minutes for people to grab their plates, find their seats, and then we'll be beginning with our student presentations. Thank you. Hi, everyone. Just a quick 5-minute reminder. We're going to start our next student presentations in 5 minutes. So if everyone is able to go ahead and grab their lunches and get back to their seats, that way we can continue on with the presentations that we have planned next. Thank you. so glad that everyone was able to have good discussions before getting their lunches and is able to collaborate with each other and their neighbors. We're going to go ahead and resume back into our program. We're going to bring up Ms. Adodu, who's a high school student who has made her own foundation to help with maternal health outcomes, and I'll let her explain her own foundation to you all. Thank you.
Good afternoon, everyone. Thanks so much for having me and for giving me this opportunity to make this presentation. And a special thanks to Dr. Idu for recommending me. So my name is Oluwaseyi Osarosa Ododo, and I'm the founder of the Osarosa Intervention Foundation. And we change lives by giving surgeries to women and girls dealing with a condition called obstetric fistula. So you may be wondering, what is obstetric fistula? This is a condition where there's a abnormal opening in the pelvic area of women. It's a birthing injury, and this can be a result of prolonged labor, child marriage, and poverty. And it causes an involuntarily leaking of urine and fecal waste. So we also have our 501c3 from the IRS. But basically, obstetric fistula is preventable, but a lot of the people dealing with this condition are usually too poor to get the surgery. So this is where our foundation steps in to help raise the money for their surgery. And so our mission is to help these women get the surgeries. And so far we've helped 14 women and given out 14 free surgeries to stop the obstetric fistulas. So we've helped 2 women to start their own business startups. So that would cost $300 for the surgery, rehabilitation, and small business startups. And then it's $100 for just the surgery. And right there in the corner, this is a young girl called Khadija. Right now she's 17, but when she had an obstetric fistula, she was 16 years old, like me at the time. And we helped her to, from having an obstetric fistula and just finishing the surgery to having her own spice business. And these are some pictures from our trip. Last year, November, we went to a city in Nigeria called Kano, Nigeria. And this is another lady that we helped. Her name is Aisha. She was 19 when she got an obstetric fistula. And now she has a hat company, and she makes babies hats and adult hats. And this is a group picture from the rehabilitation center where we gave gifts to some of the women that were dealing with obstetric fistulas. And thank you so much for listening. Please help us to change more lives. Thank you so much.
And on behalf of TSU MHREACH, we'd also like to give you a present from us to help with your studies in the future. Yes, thank you. We're now, thank you. We're now going to bring up one of our MHREACH graduate students, Takara Taylor, who will be doing a presentation on her recent research poster that she did over the summer in collaboration with TSU and Morgan State University. Takara Taylor.
Good afternoon, all. So this research that I did over the summer, I went down a rabbit hole. And so, so the title, Keeping Black Mothers Alive, a link between paternal depression, alexithymia, and maternal mortality via homicide. So we're gonna go over a few definitions. And just raise your hand if you've heard the word before. Alexithymia. Femicide. Okay, so I won't go over the definition of femicide. Enough people know what it is. Infanticide, maternal homicide, pregnancy-associated homicide, misogynoir, postpartum depression, paternal postpartum depression, prenatal depression, paternal perinatal depression. Okay. So alexithymia is the inability to recognize or describe one's own emotions. And so studies have shown that in clinical studies with patients who present this way, 89% of those patients are men. Okay, and so another one that you all weren't really familiar with was misogynoir. It's hatred of, aversion to, and prejudice against Black women. So we see this a lot in these stats, and so I'm going to go ahead and progress because enough of you knew the rest of the definitions. Okay, so I'll read directly from this. The U.S. faces a severe femicide disparity, particularly affecting Black women. Black maternal mortality due to medical neglect is 3 times higher than among white women, when femicide by intimate partners being even more alarming. Black women are 8 times more likely to be killed by their intimate partners during pregnancy, with 55% of pregnancy-associated homicide victims being non-Hispanic Black women. And so the contributing factor to some of these stats here I have found to be a behavioral mental condition such as paternal perinatal depression, paternal postnatal depression, and alexithymia, which is the difficulty in identifying and expressing the emotions. So imagine a woman, she is pregnant, she's moody, and here you have her partner who really can't identify with his own emotions. How do you do that? And so that results in, violence. So my objectives here, I won't go through everything for the sake of time. So this is what this looks like. So while everybody's doing great work with talking about the hospital aspect, the healthcare aspect, the obstetrical aspect, that is all great, but this is something that we'll have to approach systematically because all of that will be done for nothing if you have healthy mom, healthy baby, and they're just going to be killed by their dad or intimate partner. So this does need to be addressed. So my findings, I'm going to read some of the findings here. So the gap in paternal mental health resources is a significant issue gaining attention despite growing recognition of perinatal mental health. Most research and resources have historically focused on mothers, leaving fathers' needs unmet. So therefore, my proposal, which I'll skip to, is that this is a major gap in healthcare. It's almost required and expected for a mother to go in for her maternity visits, for her maternal hospital visits, her obstetrics visits, but where is dad? And so while we want to see more fathers involved across the board, we want them there, but we want them to be in a healthy state of mind while they're there. We want them to be supportive. So my proposal is that healthcare, there's some type of implementation of mental health evaluation for dad. The first thing mom is given is a national domestic violence survey when she goes in for her first visit, and that's for them to check to see if she's in an abusive relationship. And so there's no one checking on dad. She can sit there and say, oh no, I'm good. I know how to answer these questions so it doesn't put up a red flag here. But there's no one checking dad to see if he has a propensity for anger, if he has been violent before. How does he handle that? And so my proposal is that there is a paternal visit for dad. Mom goes into her visits, dad goes into his. Thank you. So my methods for doing this was an extensive annotated bibliography. And so some of the resources and data sets here are listed. And so in conclusion, really quickly, so mental health support for fathers, we've gone over that. So legislative measures, I'm wanting this, and I'm really wanting to go all the way with this to push this to be a policy. So it is imperative for legislation mandates paternal health visits to run in tandem with maternal health visits, ensuring comprehensive care for both parents. Firearm prohibition for domestic violence offenders. So as it stands, there is nothing on the books that prevents a person who's been convicted of domestic violence from purchasing a firearm. If you're a felon and you've, robbed a couple of people, you got a felony, you cannot purchase a firearm. 68% of these incidences where the mother has been killed is by firearm. So if we can implement something legislatively where if you've been convicted of domestic violence, you are no longer permitted to have a firearm or obtain a gun-owning license, then that's something that needs to be on the books as well. And so the projected outcome for this, after a systematic approach has been employed to provide mental health care for Black men, and of course this will be for all men, but this is an equitable endeavor, a reduction in pregnancy-associated homicide in Black women will decrease. So these are my references. If anyone needs to scan it, my extensive annotated bibliography, there's a lot of good research articles there. So thank you. If anybody have any questions, I'm here to take them. She has a question. I have a question down there.
Oh, sorry, I did not see your hand.
I just had a comment that I just applaud you on going down this rabbit hole. This is so innovative. I've never seen any discussion about this in my OB-GYN journals, and I encourage you to write about this, get grants about this. I think this is really paradigm shifting. It's one of those like, hit myself in the head, why didn't we think about this? And I just really applaud you and your mentors on coming up with this, and best wishes to you on this. I think this is really important, and thanks for your work.
Thank you so much.
Thank you so much. Writing on her comment, when I first came into the room, I was telling my colleague here that we needed a program where we got more men in these conversations, because look around the table. So not just in public health, but particularly in this maternal child health conversation. So to hear your work is so inspiring. So how can we support you?
Thank you for asking. I'm still in the works of that. I'm trying to get this off the ground. And so the goal is to have more dads, men available, period. Even if they're not fathers, I mean, they have the ability to. They may know someone who is. And I think that even when we look in the media and we think of maternity issues, whatever, it's just women. But dads are a huge part of that. And so I'm working on some things, but I'm open to suggestions. So thank you so much. Yes, ma'am. Thank you so much. If I may, really quickly, about that. So I had a midwife that was actually here in 3rd Ward, and part of this is inspired by her. What she would have, of course, she would have her maternity meetings with all her bellies, is what she would call us. We are the bellies. And then she would allow dads to come to the facility and meet once a month. And it was just men. She would remove herself, and she left it to the men. And so they kind of, ping-ponged off of each other, their gripes, their frustrations. We don't know what they talked about, but I know for my husband, he came back and he was like, I'm really glad you made me go to that. I really enjoyed it. And so he went to a couple of other ones, and so then my midwife called me, and she said, I I just want to let you know I really appreciate you for sending Grant. Like, you have no idea who he has helped. I can't go into details with you, but he has really helped some people. And so he never told me because guys code, whatever. But but men can help one another. And so it starts in rooms like this where we can kind of encourage them and embolden them to, hey, you a big part of this. Come on up here and help. So, but we need them to be in the right mental state to do that because they can't do what they don't know.
Thank you again to Cara. We're going to be moving on into our next segment. Let me pull this up. So first off, welcome to all of our community advisory board members and our Voices of the Pregnant and Parent Working Group. They have come in around 12 o'clock today, so we'd like to welcome you all. Just as a quick thing for our CAB or our work group members, there are 3 seats over here on this side in case anyone wants to move over to the table. There's 3 available seats for y'all to sit at. And then I'm going to invite Dr. Pounds up here to give a quick re-review of the CEC Corps and to talk to her CAB members that are here present today as well. Dr. Pounds and Kennedy.
You can't change the PowerPoint, Dave. I'm not going to go. Yeah. So for the sake of time, I think mostly everybody in the room was here this morning, except for our Community Advisory Board members. So at this time, I'd like for our Community Advisory Board members to stand. And if you could, just one by one, tell your name and what organization you represent. Ms. Cook?
Hi, my name is Trina Milford Cook, and I'm the CEO and founder of Joy Drive Baby and Wellness. I'm also an oncology navigator and a doula.
Thank you. Hello, I am Adriana Davis. I'm the founder of the Harmony Grace Foundation. Good afternoon. Oh, yes, clap, clap, clap. Good afternoon. My name is LaToya Shields, and I serve as the director of Harris County Pathways Community Hub, which is held at the Network of Behavioral Health Providers.
So thank you, Community Advisory Board. As you can see, as I said this morning, we have a very diverse group of rich experiences to help us as we move along through the community engagement. We're going to jump to just putting up this code one more time. We're going to put it up at the end. If you'd like to get more information about our community health worker program, which Kennedy's going to talk about, you can scan this QR code and indicate that you'd like more information. If you're interested in our upcoming grant, you can do the same as well.
So MHREACH and AHEC is collaborating together to sponsor 4 individuals CHW training. So it would be a 160-hour training, a 15-hour week course. And one requirement we have is that they would attend 2 maternal health-related events, just since we are MHREACH is all about maternal health. So we would like potential applicants to attend, or once they're in their course, to attend 2 maternal health-related events.
And so what we're going to do, Kennedy and I will be back again on the program to go through sort of a maternal health think tank quick session. So thank you for your time. And if you're interested in a community health worker scholarship program, there's also a flyer in your folder.
Thank you. And they'll be back up here in a little bit to do another in-person activity with everyone again. I would now like to welcome to the stage Felicia Latson, who is the work group coordinator for the Voices of Pregnant and Parenting work group. Felicia Latson is a licensed clinical social work supervisor and a passionate advocate for change for marginalized communities. She earned degrees at Stephen F. Austin State University and the University of Houston's Graduate College of Social Work. As a returned Peace Corps volunteer and a resident of Houston's historic Fifth Ward, she is most inspired by the community activists who initiate change using the tools available to them. Her professional experience spans various roles in organizations. She is the owner of the Swalis Advisory Co., a health equity consulting firm. She has served as a mental health and healthcare leader at Women's Home and Legacy Community Health. She is also an adjunct professor at Baylor University's Diana R. Garland School of Social Work. Ms. Latson.
Thank you. I've never heard that read out loud before. I was like, wow, that's long. Okay, so just to reintroduce myself, I'm Felicia Latson, owner of Swalis Advisory, and I have the honor and privilege of leading the work group for the Voices of the Pregnant and Parenting. Our work group consists of people across several disciplines. They introduced themselves earlier, so I won't read through that part again. But you see that we try to recruit a vast array of people, and recruitment is ongoing. And so just, because when doors open and you're doing what you're supposed to do, an influx of pregnant moms just came through, I think, day before yesterday. So these numbers will change, and we'll have more representation from actual pregnant moms, because recruitment is ongoing and open-ended. So I won't go through everyone's bio just for the sake of time, but again, they've stood up and they've introduced themselves for the ones that were able to make it here. And we have the support of Dr. Jones and, of course, Dr. Ajawole. Thank you very much. So I just want to kind of summarize what our groups have been able to accomplish over the past 6 months since we started meeting, I believe, in April or June with the hurricanes and everything else. I get mixed up in our months. But we spent our first work group session really just establishing our community agreements and focusing on how we wanted to create a safe space for people to share their stories about birthing experiences, either their own or the mothers that they were supporting. And we also went over just what is this study about and why are we doing this. And once we got into group 2, that's when we started to really get into the nitty-gritty of things. And we wanted to talk about what factors are negatively impacting maternal health outcomes for African-American females. And what our group came up with is that, there is just, the prevalence of inaccurate diagnoses sometimes. Symptoms are ignored and attributed to things that are less life-threatening until they present with a certain level of severity. There's also the existence of racial bias, and that bias is falling on two sides of the spectrum. We've heard about there's sometimes difficulty with locating Black doctors or receiving care from doctors that, can match a person's culture and language. But then it was also highlighted that sometimes people oftentimes perceive Black doctors as being lower quality and as having less education. So it's not always clear-cut about how race is playing into the situation of the health outcomes, because it's falling on two sides. Also, there's just the prevalence of outdated or racially biased medical education. There are perceptions that Black women are stronger, their pain tolerance is higher. They should be able to endure longer without the medication or the medical interventions that other groups may receive. And then sometimes there's just the societal mistrust between Black mothers and white doctors. And there's a lack of desire or a lack of trust and willingness to go forward with interventions that white doctors are suggesting. And then also there's lack of knowledge that a doctor can be changed. So just that self-advocacy piece. If we have people who are assigned a doctor because that's, when they call the clinic, that's the doctor that had that appointment available. Or, if they're on Medicaid services, this is the doctor that, that health plan has just assigned them to. And there's just lack of knowledge that, no, this can actually be switched. I can actually advocate for myself. And then when that lack of trust is there, mothers are less likely to speak up and ask questions and, express their discomfort and just say that they don't understand what's being explained, right? How oftentimes do we see women just go into appointments, or people in general go into appointments and say, nope, no questions. And that check for health literacy just isn't there. And so the good thing that's come from these groups is that we oftentimes come up with a list of resources, because we have this amazing think tank in our work group. And, if one service provider doesn't know something or a particular resource, then another service provider does, and we're able to gather all of those resources and keep them included in our documentation. So next we talked about what the positive factors that are in place that are impacting maternal health. And what the group came up with is that when doctors listen and they're not being just robotic and going through a checklist, that can increase the health outcomes or improve the health outcomes. And the way to show that you're doing that is by repeating back what the patient has said to you. Again, focusing on health literacy and building that rapport and working from a place of trauma-informed care. And so I am a mental health clinician, so this is very important to me. And so what we know is that 1 in 5 women have experienced some type of sexual assault or rape, right? Fully committed. And even higher than that, 80% of women have experienced some type of sexual harassment or sexual abuse in general. So if we're operating from a medical standpoint during COVID, right, we operated and provided medical care from a point of universal precautions. We treated everyone as if they had COVID, right, until it was proved otherwise. We can do the same thing for our OB care, right? Treat everyone as if they have had some type of trauma in their lifetime because the statistics support it, right? And so being able to tell a person what's going to happen at every point of that care. And it doesn't just start with the doctor when they get in the room, right? This relates to your call center, how your people talk to the person when they're answering the phone. This relates to your front desk. You know, are they speaking to people harshly when they check in for their appointments 5 minutes late after they've taken 3 buses, right? This relates to your MA, your medical assistant. Are they ushering them into the room and being very rushed and snappy with their words? So trauma-informed care is not just about what the doctor is doing in the room. And so just, again, treating patients as if they've all gone through something. Even one doctor highlighted that just taking for granted that everybody has gone through some type of exam simply because they've had a baby before. Not every woman went through that process. So if you're going to examine this woman and be inside of her body, you need to explain every step of the way that this is what's going to happen and this is how it's going to feel. That's how you do trauma-informed care. So one of the other big proponents is the WIC program because it is universally available. There are no citizenship or work requirements. It has higher income limits, and the approval period goes on for a long time. I may skip through some of these just so I make sure I hit everything. So we also talked about the specific non-medical driver of health encounters that are supporting moms as well. And so we talked about food insecurity, WIC being used to address food insecurity, housing instability. And something interesting that came up in the work group is that child welfare doesn't always consider living in the car as an unhoused situation. Now, we can see that on two sides, right? Of like, what? People are living in their car. That should be a CPS case. However, what do we know about CPS and the disparities that CPS involvement can cause in the lives of Black women, right? It's not always a great outcome. So if we can take a broader look and say, well, do they have access to water, food, and toilets as needed? Can that car be considered shelter, right? So that can be a more equitable way of looking at someone's situation and not just using this standard viewpoint of like, oh, their housing does not look like my housing, therefore it's inferior. Also, there is great work going on at the Network of Behavioral Health Providers in their collaboration with Memorial Hermann to provide case management and hotel vouchers to people in unhoused situations when they're being discharged. So we also talked about financial status and how that can impact when a mom is coming out of the hospital. Hospitals require a car seat. We understand, yes, the baby needs to be safe. However, what are the finances around being able to obtain a car seat? And I think I'll talk a little bit later, I might be skipping around. There is a program called Safe Riders that's across Texas. And at one point, they did not require that a person had a car in order to get the training from Safe Riders and be able to then get that car seat awarded to them. That has changed, and now a person does have to own a car. So we have a program that could eliminate a barrier, but then we put in a stipulation that recreates that barrier all over again. Am I going backwards? Okay, no. So here we got into some big dreaming. Like if money was no issue and we had a magic wand, what types of interventions could we put into place to improve health outcomes? And one of our participants suggested like tiny home communities, right? They don't cost a lot to put up. They're easily maintained. And then you have built-in peer support from other mothers where they can be able to address their own needs and be the experts in their own stories. And it's not always up to the service providers to come in and solve and save someone. Having early intervention in maternal care that's not necessarily clinically related. So again, it kind of goes back to that peer support by having walking groups or yoga groups or anything that's not involving actual medical care. Also, someone had a great idea of creating the equivalent of a children's assessment center, but for maternity care. So if anyone has been involved, again, in child welfare and sexual abuse, you go to the Children's Assessment Center, law enforcement is there, your social service provider is there, your medical providers are there, your mental health providers are there, and that child never has to retell their story over and over again to all of these different people. Why can't we replicate that for pregnant moms, right? And have all that data shared all into one place and not having that pregnant mom, use the bus from one service provider to the next. And then just the idea came up to increase access to care. So starting postpartum care at 3 weeks instead of the standard 6 weeks. Using your doulas and midwives to intervene at 24, 72 hours and then weekly after that. Maybe they can help serve that, fall into that gap and be able to bridge that gap. I think somebody is later going to talk about the patient safety bundles and being able to apply those more widely. And then just increasing home birth options. And like, here we talk about the burden of the car seat requirement. And so in our fourth work group, we got into how specific, or what specific non-medical driver of health supports have been utilized. And so we talked about the round trip program, which I'm going to take a minute to just give myself a pat on the back. This is the program that I started during my time at Legacy Community Health. It was put together by a group of passionate students that I was working with. One of my students came across the program that Lyft was already running in other cities. We researched it, we mapped out a plan, we figured out how to get it funded. Fortunately, the agency put resources behind it. Episcopal Health Foundation or Methodist came in and put the financial supports around it. And it's still running today thanks to the amazing work of my colleague, William Lyons. He's still over at Legacy. And so with this program, we were able to bring pregnant women into their maternal visits more frequently and more consistently, regardless of what clinic they were attending, regardless of what legacy clinic they were attending, and regardless of where they lived. So I specifically had a patient that lived, I believe, in Porter, and she was getting her care in Montrose or Fifth Ward, somewhere in central Houston, and we picked her up for every appointment, because what bus is going out to Porter? None. And she delivered a healthy baby. So I'm really proud of that. My little moment. But there are also other great programs to tie into for transportation, like the Medicaid transportation program. And then the group also highlighted the importance of other programs that are filling those material health needs. So just going somewhere to get a diaper, going somewhere to get appropriate baby clothes or maternity clothes so that I can keep my self-esteem up and I'm not, still trying to wear the clothes from, 5 sizes ago. And so we also talked about some other wide-scale programs. Again, Harris County Public Health, they've talked about their programs. And with the Healthy Start and the CHWs that are helping mothers navigate. And they have 2 levels to that program. One that's targeting at 14 core zip codes, and then another one that is going into the family's home. And also we talked about the Safe Rider program that provides car seats. And then one of our OBs that is on the call, she talked about the value of having telemed visits, especially when you don't have to examine a woman. And she stated from her experience, These visits allow her to do better patient education. They're not rushed. The mom is not frazzled from having to arrange childcare, get transportation. There's not multiple people like the MA and the front desk all involved in how the interaction will go. The person is able to log on from a place of their own comfort and really sit down and have a focused conversation about what's going on with their body. Okay, and so we also talked about other supports that are used, and so having doulas that are involved in the delivery process, and this allows the parent or the family just to really enjoy the birthing experience without also having to have that advocacy hat on. So I'll skip ahead because I know I'm running out of time. Oh, and so we have had work group 5, but that didn't make it into the slides because it was more recent. But here we talked about the specific or how specific non-medical driver of health interventions needed to happen. So with respect to cultural competency and not working from a standpoint that people are unengaged or disengaged because they don't want to be. Also designing programs with the idea that we are serving people that are working 2 and 3 jobs. And so why do we just assume that they should be able to come in to receive our service between business hours? How are we accommodating people that are in the ALICE category, what's sometimes called as the working poor, and making sure that we're designing programs for access, right? And not just for the benefit of, well, we're here and you need us. So making sure that we have that cultural piece in play. So I'll take any questions if there are any. Thank you.
There you go. Any questions for Ms. Latson? Oh, in the back.
Yes.
Just really quickly, can you expound or clarify your Safe Riders or the passenger program? Is that car seats for mom? Can you, because I might.
Yeah, so that's a state of Texas program. And from what I understand, different agencies can apply to the state of Texas to become a Safe Rider site. So in the instance of Legacy Community Health, they have the contract with the state, and then they have the staff within the clinic that actually administer the curriculum. So mothers will come on site. I believe in COVID they did it virtually. I don't know if they still continue to do it virtually now, but mothers will come on site. They receive the curriculum. I believe it's maybe 3 to 4 hours long. At the end of the training portion, at Legacy, it's community health workers. They actually go down to the car of the mother and show them how to buckle the car seat in, and then the mother has a car seat. If anyone else has any updated details, feel free to share. My time at Legacy was a few years ago, so did that answer your question? Mm-hmm. So if you look on the state website or just Google Safe Riders, it can give you all the information. Any other questions? Yes, ma'am. So I don't have a program particularly, but I'll address the point of used car seats. The reason why used car seat distribution is discouraged is because car seats do have a lifespan, right? They're designed to only take so many hard impacts. And then the car seat really needs to be adjusted for the child's height and weight over time. So you don't want to just give someone a used car seat because you don't know what that car seat has been through, and you don't know the expiration date if you haven't owned it the entire time. But there may be, so those, where we talked about diaper distributions or clothing distributions, sometimes those programs are more so run through like local churches or smaller community organizations, and they may be able to accept those things, but used car seats are generally discouraged. Absolutely. Yeah. Any other questions? All right, I appreciate your time.
Thank you very much, Ms. Latson. All right. We are going to be moving into our second strategic planning session. So this one's strategic planning for improving maternal health in Harris County and greater Houston area. This will be led by Dr. Pounds and Dr. Olale and Kennedy Norwood. So they're coming up with their poster board right now so that we can begin our second interactive session for the day. And then we'll also have our volunteers. Thank you to our two volunteers, Brett Afiwa and Dr. Titi Lope Dokunmu, for helping out with microphone passage during this event. And
So firstly, I want to thank all the presenters before us for giving a great presentation. Can we give a round of applause to them, please? So we've gained a lot of valuable information about maternal health overall. So we have 2 closing questions from the Community Engagement Corps. The first one is, what topics in maternal health should MHREACH focus on, specifically with educational outreach?
And so what we'd like for you to do is, so that we can keep a good record of the input that you give us, use the post-its that you have to just think of some maternal health topics that you think we should be focusing on as we do outreach in the community. One of the things that we do give information on is risks for maternal distress. So if there's some other topics that we need to be keying in on, please just indicate that on your post-it. Oh, it's not staying.
we're just trying to adjust it.
Oh, thank you. And so we'll give a few minutes for that.
I didn't give them the second question.
The strategies after. We'll talk about it. We can do it a second.
Okay.
I'll get you a bite. Okay. Ashley, get something on paper. It doesn't matter. Just and Ms. Farnetto had a good question. She asked if it was non-medical. It really doesn't matter. Just based on your experiences and your work in the community, what areas do you think need to be enhanced when we go out to talk to women in the community? Dr. Szymanski, we know you're going to say environmental health. But it is important. Dr. Szymanski leads the Maternal and Infant Risk-Cape program at Baylor, and that's where we look at how the social and physical environment impact maternal health. You can, and we can write it.
Or we can put it, we can just...
Oh, no, you can write it on your Post-its.
Write it on the Post-its.
Good. Okay, so we're going to give you 1 more minute, and then we'll collect any suggestions you have. Need a marker so that if we need to expound, or you can type it, I guess.
Okay.
Right, go ahead, Asha Wiley. She's ahead of you.
Did it fall?
Does anybody else have one? Okay. Thank you. Okay, so we'll read these off. Ms. Cook mentioned mom prenatal health and professionalism. Tell us a little bit about when you say professionalism.
Well, when I say professionalism, I work also as a doula and also as an advocate as well for women. And so a lot of the times when I go into the hospitals or just sometimes I go with my clients to their doctor's appointments, or maybe they call me late at night and they say that they have to go to the emergency room. So I meet them there at the emergency room. A lot of the time, not all the time, but a lot of the time, the doctors, they talk to them in a discouraging and disparaging way. And so my thing is I tell doctors, I don't care if my clients are paying you peanuts or they're paying you with Medicaid or private insurance or whatever. You are supposed to treat them with dignity. You're supposed to talk to them. You don't come in and you don't say things like, hey, little mama, or, things that are not professional. And so my thing is, if you're being paid to do a service, do it to the best of your ability, because if someone's paying me to do a service for them, I'm not coming in, I don't care what you're paying me with, I don't come in and say, hey, little nappy-headed girl, or hey, crazy looking. I don't say any of those things. I say, yes, ma'am, yes, sir, how can I help you? What is it that you need me to do? And when I say professionalism, that's what I mean. Doctors need to treat women, with professionalism, with dignity. They shouldn't be afraid to talk to their doctors and tell them what's going on with them and tell them what's going on with their body. And so when I say that, that's what I mean by professionalism.
Thank you. Does anybody have any comments about that? And I'm also going to add, so it sounds like, too, you're saying give patients a checklist of kind of what to review with the doctor.
Well, and that's what I do a lot of times, and I commend That's what I do a lot of times, and I commend Harris County for coming up with that Bill of Rights, because I tell a lot of people, a lot of times I can't be there because I do have a background in law. And so I can't be there all the time to advocate for you, so I need your husband to be able to advocate for you. And I commend Harris County for having that Bill of Rights, because sometimes women need to know what my rights are, what I can and what I can't do, what I can tell them that I want them to do and what I don't want them to do. I had a client and she once felt like her water hadn't been broken, but they kept ignoring her, and I was far from where I had to get to the medical center. So by the time I got there, she still kept telling me, Miss Trina, my water's still in broke, but the doctor and the nurse kept saying, well, you wouldn't be here if your water wasn't broke. And so because I don't like people to continue to make my clients seem like they're lying. So I said, well, can you just humor us? Just humor me and just check. And just as they went in there to check, all of a sudden a gush of water came out. And I said, oh my God, what is that? So that's what I'm saying.
Thank you, Ms. Trina. So some other areas or topics that we should be focused on are stress, child care, support in community and mental health, and spousal support. We have a couple for spousal support, including father's involvement through the journey. We actually have one of our CAB members, Mr. Nathan Maxey. That's actually one of the things that he's really pushing for us to find ways to involve the men in some of the things that we're doing. I also want to point out that Takara was on our Black Maternal Health Planning Committee last year, and one of the things that she proposed too was including them on our panel. And so this year we're going to try to push to do that. Breastfeeding and education classes, nutrition, and nutrition that is relevant to the family's culture. Who brought that one up? Okay, you want to share with us some more about that?
Sure. So the way that I see it is a lot of families, they come from maybe a large family and they can only afford a certain type of food for the entire family. And so they can't just designate a certain type for the growing baby or the mom for their nutrition. So just finding something that could encompass the whole family and taking that into account and making foods that are of nutritional value that are also good and culturally relevant for the families as well.
Thank you. I'd also like to see, I know we have some people who are online. Was there anybody in the chat that had any comments? Hey. Is it going to be in here? Oh, thank you. No wonder he looking at me like, what? Okay. Okay. All right. So just want to make sure we're including our online followers too. Next, we're going to ask, coming out of COVID, I know as we work in the community, I myself am finding that it's much harder to reach people. And so wanted to ask you all as the experts from the community, how are you reaching people with information and education? We have an initiative in another project I work on in MHREACH where we're trying to reach out to groups of moms to talk about emergency preparedness. But we've had the toughest of times trying to get intact groups or invite individuals to come. So just want to pick your brains about how do we reach them with the information? Like, what are some strategies that are working?
Hi, so one of the things that I try to do is just connect with local doulas as well, but also I'm a doula and a mentor and a CHW in training, but I'm trying to connect with male doulas in the community so that I can move forward with men's mentorship, because that's something that I really personally connect to and value and have found value and find value with my clients, that their partners, if they have them, really need that because they don't know what they're doing. And and that's okay, I guess, but we want to change that. So getting men involved in mentorship, not only in fatherhood mentorship, but just men's mentorship generally is really important. And so the ways that I've done that is, again, connecting with male doulas in the Houston community, as well as reaching out to fatherhood Instagram pages that I know are run by Houston groups. And also, I am also spanning my reach into other worlds. So not only in the doula world, but in the yoga world as well, because there's a lot of consciousness in that community. So I'm trying to start normalizing men's mentorship in that world because I know it's already there, and then hopefully expand it to bring it into general Houston population, but specifically with my clients. That's something I always speak to, and that's something I always offer. I always offer men's mentorship and also family mentorship, and specifically postpartum mentorship to my moms and their families. So promoting postpartum and prenatal mentorship is really important for the man aspect of like the spousal support, which is what I wrote on my.
And I like that you said the family mentorship, because we know that it does take a village, but I have to admit, oftentimes we really don't think about, we don't think about even asking the mom, who is part of your village, and bringing them in and inviting them to be a part of the educational process. So that's a great suggestion.
Yeah, and that's really important also when you have multi-generational homes, because, I mean, I can't tell you how many times I've heard of certain communities, the parents thinking they know what to do, like the grandparents thinking they know what to do, and like the last time they had a kid was like, 30 years ago or something. So it's like, things have changed. This is also America, So there are just different things. And so letting them know and creating that space, because a lot of times with my clients that are younger, they don't feel comfortable having those conversations with their parents. Or I had a client that lived with her partner's family. So it's like, there's a boundary there, not only culturally, because I believe they were Nigerian and she's not, but also she was under 20 years old and lived with them. So it's like, well, that's not really my mom. Like, I can't really tell her, whatever. So things like that, it's really important to have the family involved, and for the doula or the whoever's like on the outskirts of the family to create that mentor, therapist, whatever, to create that safe space for the mother to have that communication, and also create awareness with the elder generation of like, listen, like, that's not how we do it anymore. And like, just creating that line so that communication can happen, and so that the mom doesn't have to do that. Again, we're advocating for the mother, but instead of only in the hospital or in the birthing room, we're doing it in the home.
Right. Thank you. Thank you. Latoya?
Yeah, I think going back to the question, how do you reach those individuals or women that need support? Was that the question? And I think it's challenging across the board. I mean, I think all of us work in this field, and we can say it's challenging. But one thing that does work with some effort is just really building those partnerships and collaborations. You have to bring the information where that woman shows up at. And she shows up at your hospitals, right? She shows up at your clinics. She's showing up at the food bank. So she's not always going to come to our cute health fairs that we have and all those types of things, but we have to be very person-centered and person-centric, and that means we go where they are, and they're not coming to us all the time because of some of the barriers that we're talking about. So that means we do need to go to the hospitals and be a little bit more intentional about how we partner with them. We do need to go to clinics, FQHCs, because they're showing up. And we need to be a little bit more intentional about how we partner with them and helping them understand the big picture. So yes, they're coming here for their maybe physical health or behavioral health appointments, but we also have emergency management support that we want to give them, emergency preparedness, and maybe what you have to offer can get delivered through a partner. But I think we have to be real and understand that we got to meet people. We really got to meet people where they are. And I think that's one of the ways that we're learning in my program how to do that.
Thank you.
Just quickly to add on to that, some other places where mothers might frequent, or those people that need support might frequent, like libraries, because they have a lot of child programs, parks, because children are there, hair salon, like places, of community, places of like free childcare, free accessible childcare, and just other places that are like, outside of the box of typical, like, oh yeah, you're going to the doctor. The WIC office, it's another place we can go and we can just say, hey, have you heard of what a doula is? Do you know what a midwife is? Like, things like that. Here's some information. Here's your Bill of Rights. Like, just passing those things out in those spaces. If you see a pregnant woman walking down the street, like I do this all the time in my neighborhood. When I see pregnant women, I'm just like, hey, here you go. Here's the Bill of Rights. You look really far along. Don't let them prick you more than twice, okay? I've had a client that got pricked 6 times. Yeah, it was pretty horrible. But yeah, just going to those places.
Thank you for being a voice. Oh, I think she wanted to say something first. Did you want to say something?
All I was going to say was, we talked about this earlier, and I think what we're talking about is changing the community culture about maternal health. And I think that, we have asthma-friendly schools. Why can't we have, maternal-friendly workplaces and places of worship? Every woman should be able to breastfeed without stigma and not in a closet somewhere. And I think there are ways to do that by educating the entire community and then maybe even enrolling businesses. They're more likely to attract women to come to work for them if they know that they're respected and that their roles as mothers will be respected as well.
Good. That's good. I was going to just kind of piggyback off of what Ms. Latoya said. So I also think that it is important to continue to have these conversations with community-based organizations or large entities that are already involved with participants, because sometimes the participants are in multiple things, and so it just makes it be person-centered to just meet them where they are by using our agencies or our community-based organizations that are already meeting them. And so just kind of presenting whatever information you want to these organizations or agencies and having them help you disseminate the information that you're trying to convey.
Thank you. Anybody else? Okay. Thank you. Thank you for your time and your sharing of your experiences. Cecilia? Oh, Oh no, like Trump got dancing.
Sorry.
I'll use this opportunity to thank everyone. Let's give it up for everyone. Our Community Advisory Board, Voices of Pregnancy, we truly appreciate you. And Cecilia now has, she and I believe Jasmine were tasked with creating some innovative bundles, both for our mothers, fathers, but more importantly also for our providers, all the healthcare providers and support personnel that interact, our CHWs, doulas, midwives. What type of things can we use to bridge the gap that we have in knowledge and access? So go ahead.
Thank you again. And again, thank you all of you for your input today, for both of our strategic planning meetings. It's been very helpful and very vital to making sure that we move the needle on improving maternal health outcomes for all across Houston and Harris County. We're going to go into our last segment where we're going to go over maternal health bundles and some of the work that me and Jasmine have been working on this past year. Just a quick note, this is actually both within our first year of working here at TSU, and so we were able to hop right on with MHREACH right when they were starting off. I just passed my 1 year mark, and Jasmine's been here like 3?
This will be my 3rd month going into my 4th.
She came to us straight after graduation, and she is now a fully licensed pharmacist as well. So first we're going to go over, so when I first came to TSU, I actually was initially fully 100% on our CBMHR, our Center for Biomedical Minority Health Research grant. And in it, I wanted to still focus on maternal health research as this was one of my priorities while I was in grad school. And so before I even joined MHREACH, I started writing our racial disparities in maternal, infant, and life expectancy outcomes in Texas Harris County. This was originally my first assignment where she told me to write a report. I kind of got a little carried away in the epidemiology section of it, and it turned into 250 pages of a report. So it had to be relabeled into a book. We're in the process of kind of finalizing it, and as Harris County Public Health had stated earlier, obviously this data is changing every day, but it was the most up-to-date in the time of writing it, and we hope to get that out soon. And so TSU is working on this report with me to make sure that we cover maternal and child health within Harris County, and hopefully it'll get published soon. Then next, one of the things we want to be able to ask is that we are in the process of creating a maternal health bundle. In this bundle, we want to be able to create a care package that we can give pregnant and postpartum women to assist within their maternal health journey. So this is just going to be health-related items, personal care for the mom, baby, dad, development of maternal health care, and a potential support app that we're thinking about creating. And so I kind of just wanted to ask everybody, when you think of a maternal health bundle, when you think of something that we can give the mothers to help in their maternal health journey, what are some ideas that you have? And then we'll turn it over to ask, and go her first, and we'll turn it over to some of the items that we're looking at already having.
This may be a very untraditional response from the things we think of in newborn bundles and maternal health bundles, but speaking from a very unique experience I had with a participant in Black maternal health, when you're working with someone who has so many different social determinants of health and so many different needs, the most basic thing is so imperative. We don't think about basic cleaning supplies, right? So we had a mom who was so much to get her to or from, get to the hospital, she's ready. And we're like, Lysol, wipes, tissue, napkins. It's like the most basic things that doesn't come with, okay, we need the little baby diapers and the wipes and all of that's important, but I just wanted to say that just so we can all kind of think outside the box and understand that too can go with the package and the bundles. It might seem simple, but just having a Clorox wipe can be a big deal for those who don't have it. So, yeah.
Such a great comment. And also, there are ways to make economical, low-cost cleaning supplies at home, and so including instructions and maybe like even a starter kit with, you know, a lot of with the reusable cloth that can be used, but we work with local groups in Atlanta who to do education with moms on how to make their own cleaning supplies, because not only are they affordable, but they're also less toxic as well.
Thank you so much for that. I believe she had raised her. I'll come back around. Just want to try and get in order.
Yeah, no, you're good. My only comment really was, those are actually really great suggestions, but I feel like we need to be more inclusive of different family dynamics. Not everyone is mom, dad. So maybe being mom partner. I mean, there are plenty of, same-sex couples that are having kids these days. So maybe being more inclusive of that. And then also, I know that some things that are happening in that same vein is there are some same-sex couples, specifically women, that are both attempting breastfeeding. So maybe trying to figure out how to support that, because I know it's possible for a non-pregnant woman to breastfeed. And so just being supportive in that journey, kind of getting a bigger picture of what that family dynamic looks like and what specifically their goals are with parenting and with involving both parents in that parenting journey. So that would be my contribution.
Yeah, this way, or skirt around.
Just maybe a list, helping them to identify who are their supporters. Having that maybe somewhere where they write it down, the list of people and the phone numbers, just so that, one, it helps them identify who is their person, and two, just in the event that, a friend comes to visit and notice something is wrong, they can say, oh, okay, let me call this person. If they're not here, to be able to help them, that'd be real great.
Just kind of piggyback, having an advocate, somebody that they can reach out to. But I wanted to just kind of comment on things in the care package. Considering, and it may have already been said, things like Vaseline, diaper rash ointment, even cough medicine. I think, we do the diapers and all of that, but then the baby gets sick. They don't have the money to go to, the pharmacy to try to pick up something, they always have a little runny nose and stuff. So I think that needs to be considered as well.
So at the Harmony Grace Foundation, we provide care packages, and in our care packages, we do include the Vaseline, the lip balm, we include socks, but these are for families that are already in the NICU. So when we think about maternal health bundle, when they get ready to go to the hospital, thinking about the socks that they need, thinking about maybe like t-shirts that they may not have. So I like all the basic stuff as well, because we put Kleenex, when we do get donations from wipes and diapers, we will include those as well. So, we have Kleenex, lip balm, we have socks. When we do get donations from for diapers and wipes, we will include that. We include a journal, a book. We include a book for them to have, and we may leave a little nice note for that family to encourage them. So that's what's included in ours, and I think it would be helpful to include it in your maternal bundle as well.
And I just wanted to add a couple items that are beneficial when we're talking about, we mentioned some really nice items here, but what about those pads? And what about the feminine products? What about underwear that are, undergarments that are very specific to someone that just had a baby? So we oftentimes don't think about those things, and those are things that can aid and support the mom, give her some of the comforts that she needs so that she doesn't have to think about those. So I just wanted to add to the list.
And I want to add again, because I did forget, we do include Uh, I would definitely add the toothbrush and toothpaste because the reason for the products that we include is because when I went through my journey in the NICU, I would leave my toothbrush at home. I would leave my hair comb. So that's what the idea of including those items in those care packages. So toothbrush, toothpaste, mouthwash, like your basic hygiene products. So.
Yes, thank you. Preference, or I'll just go first.
That's great. A woman does need pads and access to them rather than sending their other to the store to try to get the pads for them. It can be uncomfortable because they're like, what kind? How big? What's and then they have the Senate kind and all this kind of stuff. I would also recommend some sort of feminine wash so that they can have a feminine hygiene wash to get all their men in the room nooks and crannies, so that they take care of that. The other thing is that I breastfed my children, so I would say the breast pads, because women that are breastfeeding, you tend to, when your children start to go array, you'll start to leak. So you want to make sure that you have breast pads for the moms that are breastfeeding.
I wanted to pivot a little bit because a lot of the bundles that we are including are for mom and baby, but we need stuff for dad too. And caregivers as well, because again, it might not be a traditional home, but it might be a caregiver that's helping with the infant that's growing. So having maybe some books that would help for emotional support for the father or the caregiver, something to keep them busy while mom might be hospitalized, something like that. I personally go for the 5 love languages. That's just my personal thing. But something that would allow for them to become a little bit more aware of themselves and of those that are around them as well. So that's just my little tidbit.
One more, so Miss. Just so we can keep on time. Miss, so I'm just
Just really quick, along those lines, also just like a little book or something for the sibling or siblings, because there's a lot of jealousy with older siblings, and maybe a little book about, welcoming the baby into the family.
Thank you all. We're gonna flip over to our next slide just to keep in review, and then we could probably still do a little more. We appreciate all your suggestions. We have them written down. That way we can look into putting them in our packet. Yes, I know, but I'm going to show the next slide, and then yeah. See if I can at least get the laser. There we go. So this is part of the initial stage of our maternal bundle that we have planned. So we have blood pressure monitors, so that way they can monitor their blood pressure at home. This is also in line with our MHREACH project. We want to make sure that women in their postpartum stage are able to control their blood, or not control, but monitor that to make sure they're in good health. We also have some diaper bags, 40-ounce water bottles, because we know that they need to stay hydrated throughout their whole time. Medicine bags, some bibs for the baby, lip balm, pumice stone, a blanket, hat, and some pill boxes to help out. So these are some of the current items that we have planned for within our box. And so we will definitely be adding more with your suggestions that you have given. And so kind of just adding from this, I will reopen the floor. I just wanted to make sure that I could still show this and still get suggestions from y'all based on that. I'm going to go for it. Which one? Are you referring to this, or? Oh, sorry, yes. I just realized, yeah, it's white. It's a. This right here is. Right here? That's a bib. That's a baby bib. Right here? Here? I can. That's a pill box. It's like Sunday through Saturday pill box to put your medicine in. Okay, yes. Write that down, Dr. Pounds. Yeah, sorry. This is a pill box right here. This blanket, stress ball, pumice stone, lip balm. This right here is compression socks. I know it's kind of hard to see on the white background, but there's a compression sock right here. Sorry about that.
It sounds like to me that something really valuable and that people always reach out for anyways is like a resource list. Possibly, if possible, organized by cost and location. Low cost, medium, and high, and then locally, where is it located in Houston, in the greater Houston area? That's super important, and then maybe even a little section on like domestic violence resources and things like that. Mentorship or therapy resources that offer free therapy or low-cost mentorship. Me personally, I offer low-cost mentorship for $35 an hour. But just things like that, I feel like could be really helpful, and just a little like piece of paper or something.
And just real quick to piggyback, just because I remember it was said earlier with like the resources, it's not on here, but CDC and DSHS also have like various forms for like resources in terms of, and kind of like help guidance for like if you're seeing this within your body, if you're seeing these changes, like this is the type of help that you should be seeking out. So we also have like those information guides. They're just not up here in terms of products, but we do have those pages ready from like CDC, DSHS. But yes, sorry. Perfect. Yes. Yes. Yes, we'll have like the information booklets, pages. I think we currently have like 10 different like pages of stuff for that. But I just want to make sure I mentioned that just because it wasn't enough room. Yes, it has all the pictures on it.
I also want to plug MHREACH's website. We have a whole bunch of resources on there. We added a whole bunch, and we also want to say for October, we know it's Breast Cancer Awareness Month, but it's also Domestic Violence Awareness Month, and we have a whole bunch of resources on the website for that as well. And what is that website? It's MHREACH_Linktree. Linktree. I can give it to you right now.
It's MHREACH, MHREACH _Linktree, LINKTREE. Huh? Just that. She has it. She's the one that the official website. Anyone else for the mic? All right. Let me go this way. You're next.
All right. Good afternoon, everyone. I'm Jasmine Jones. I'm back. So I'm here to talk about our culturally competency toolkit. So we are hoping to develop a cultural competency toolkit to provide to health providers, hopefully in the Texas Medical Center, with a focus in maternal health for our. We're still determining if it would be a good idea to focus on Black mothers or if we open it to minorities as a whole to see how we can best help our patients in our area. So our question to you is, what would you guys want to see in a healthcare provider specific toolkit that we can distribute in our hospitals for maternal health?
It's me again. I think several things that come to mind, but I don't, what kind of information can we give? What kind of leaflet, pamphlet, something that people can see that at least opens up the eye or opens up the conversation for implicit bias or bias? I said it. So what can this group do? Because if we're going to, this is great, but what can we do to open up conversation or say, oh my gosh, implicit bias, even if they just look at it, just some type of information about it? And maybe what can the group do to open up a bigger avenue and make sure that these systems hospital systems, clinics, providers, that they are getting the training that they need around that. And I'm done for the day.
Thank you.
So I think it's important to show like the numbers and the disparities, and that's number one. Number two, it's important to understand the causes and the timelines of that, and things that we can do to address, well, so severe maternal morbidity and mortality. So the kind of the facts. So we understand, like, yes, this is a problem, and to do it in a way where, like I don't feel like I'm being blamed for things. Do you know what I'm saying? Like, in a way where we're all respecting each other. And I think that, I mean, I've worked with Dr. Olalea in this team, and I'm not saying I feel that way. I'm saying this is how, what a provider it would need as part of that toolkit. What's that? Yeah, in the dashboard, like to understand, like, what's the scope of the problem, and then also I think understanding, like, sometimes when patients are really quiet, like, I might interpret that as a patient understands, but like, help me understand, like, what that means, like, so I don't make assumptions, because I might make assumptions based on my culture that means something else in someone else's culture. So kind of maybe, I guess, translating maybe some responses and some questions that I can ask to help to be open-ended, that would help to open up a conversation where a patient would feel safe. And like, I can't remember who was, maybe it was Felicia who was talking about trauma-informed care. I actually haven't been trained in that. I was older. I think it wasn't being taught when I went through training. And so something like that, like, I would love to learn about that, and maybe information about that. Yes, I'll come see you later. But, learning about that so I can understand, like, yeah, how I can be sensitive, and how in ways where I may be being insensitive, but in the process where I don't feel like, where I don't feel bad about myself in the process too. You understand what I'm saying? What? Like a villain. Yeah, where I don't feel like a villain. Thank you. That's her words, but thank you. Yeah.
I think it would be helpful to have information about the different community resources and programs for the providers. Everything goes back to breastfeeding for me, of course, because I'm a lactation consultant, but one of the biggest barriers we experience sometime in lactation is a family that is having breastfeeding issues goes to the pediatrician or the OB-GYN, and they send them home with a box of formula, or they don't address the issue because they don't know. They were not trained. But if the provider has the resource to the MCH program, to Houston's program, to all of the different resources, to MHREACH, if they have that information in that toolkit, then they can say, you know what, I don't exactly know this particular area, but I can get you to the professional that does. That way it's not, I have to fill the space with words, even though I may not be giving you the correct information.
I just had a quick comment, because I know we always talk about the doctor-patient and that actual OBGYN, but as you were talking about, like, that person and those resources, what came to mind is there really needs to be conversations, I think, that we start having with the people that make the decisions about who they're hiring to be parts of these teams. We know that there's a lot of CHW advocacy going on, so identifying the people in the communities, but also teaching the provider, like, the role of a community health worker and what they do, because they may be able to push from within for getting people like this in their areas. I don't know, it just came to mind.
I put just compassion fatigue for providers, for healthcare providers, recognizing what those signs are, so that they can become aware of that and kind of work around that so it doesn't come off onto the patient.
I'm thinking maybe make a sample sheet that shows if a patient says, you know, I'm not feeling good, then the doctor doesn't come back with something negative or derogative. Maybe have an example of a woman saying, maybe my stomach is hurting, or I'm bleeding, or different statements. And then showing the doctor, you know, not trying to push words on, but showing our doctor how he should respond instead of him, you know. And of course, we can't fix every doctor's bedside manner, but of course, we want them to treat women with integrity, because studies show that a lot of women of color are afraid to tell their doctor certain things because they're afraid their doctors aren't going to care, don't want to hear it, and if they do tell them, then the doctor's going to be like, okay, I hear you, but he's not really hearing them. So my thing is, when I go with my clients, I say, and I'm there with the doctor, I want the doctor to tell back to my client what he heard her say, so that I know that he got an understanding of what she is saying. And so my thing is, I think there has to be a flyer in these books that were given to these doctors that show them exactly, give them a little sample of how to actually talk back to clients, and not talk to clients, but talk back to them in a professional manner.
That's a really good point. My husband's an ER physician, and he had a black woman tell him, my breast is hurting, and she was having a heart attack. So to your point, I think that's really important. It's not to necessarily, like, to really ask more questions rather than just, oh, her breast is hurting, like, that's not breast cancer. But, you know what I mean? Like, don't make assumptions. Ask more questions. I think it's really important to remind us about that. I love that idea of, like, the little vignette. And then to Dawn's point, I keep writing app, like some way where we can access resources like online, I think and that is kept updated. Maybe we could use something like the MHREACH or a future funding source to get that through. I don't know, maybe Harris County or maybe Houston Health Department. Maybe someone already has something like that, but kind of a clearing, I don't know, is it called a clearinghouse or whatever, where we could access information like that, and how maybe you guys are the ones that know that because you interact with the patients so much, but a way that we can get information like that. What's that? An app, yes.
I get what you're saying.
Yeah.
Like a phone app? Yeah.
Like an iPhone app.
Yeah.
Like an app.
Can you make an app?
I cannot make an app.
I was just going to give you an idea so you don't have to start from scratch. Always build on what's already out there. There's a guide called CLAS, C-L-A-S, Cultural Competency Guide. C-L-A-S, class. But yes. So use that as your jumping point, and then I think it's specifically for mental health and substance use, but you can use that to build on the maternal health. Don't start from scratch.
Okay. One more question. One more, I guess, statement.
It's real quick. I hope that y'all will think about collecting stories and creating vignettes that can be used in nursing school, in medical school, in every school that there is, because untraining somebody who's been trained poorly is not as easy as it is to get people before so that they know how to do it right.
Thank you for all your comments. We are writing them down to hopefully use. Before I wrap up, we do have a maternal and child care health education and outreach conference, January 24th. It's in the flyers in your folder, but for our afternoon session, we're trying to have another roundtable discussion focusing on the toolkit. So if any of you guys would like to sit on the roundtable discussion, you can reach out to me, Jasmine Jones, and I can hopefully coordinate you on the panel.
Awesome.
Thank you. Please appreciate these amazing ladies. Thank you, thank you, thank you so very much for the contribution today. I just want to share some additional highlights about the January conference. So on the flyer, it says 11 to 3, but we have expanded it now. It's going to be from 10 to 4. The initial segment is going to be focused on community members. So I've already tapped the shoulders of several people in this in this group that will be sharing resources, because we don't want these great resources to be the best kept secret to the community. So we will be, reaching out to different groups to present. We're going to have, shared stories. We're going to have opportunities to engage directly with the community. This year, January, I want to believe we had about 150 people in attendance in person. So this 2025, we're hoping to get, 200 to 250 people attend in person. So registration is already opened. Scan the QR code, join us online or in person. And like Jasmine said, the later portion of the afternoon is going to be for healthcare providers. More information will come about that. The back page of the flyer is also highlighting our clinical research and engagement conference, right? With all these things that we are saying, we want to also be very intentional in increasing clinical research participation. Right? Clinical research is really where the innovation and everything is stemming out from. So TSU recently received funding to become a clinical research site, and I have the privilege to lead that. Dr. Lale talked about it earlier. So please, we will be sharing a lot of information about that clinical research program, and this event is going to be on April the 12th. It's a Saturday from 9 to 3 p.m. Registration is also open. Please feel free to register and be a part of that event. Thank you very much.
Yes, thank you so much. And with that, we are at the closing of our MHREACH Community and Key Stakeholder Collaborative Symposium. We thank you all so much for attending. Before I give the mic to Dr. O for closeout remarks, I would just like to ask that everyone fill out our MHREACH Stakeholder Evaluation Survey, just so we can hear about how we can make this event better in the future and that we can improve upon ourselves to make sure that we are always doing our best to improve maternal health outcomes. I will also be sending out this link to everybody in an email just in case if you weren't able to get it through the QR code. But yes, thank you all, and I'll give it to Dr. O for closeout remarks.
Thank you so much. I would like to start by thanking the entire MHREACH team. Give it up for yourselves. Thank you so much. And this, I don't know about you, but I've been so blessed by being part of this conversation. I was telling Cecilia that I feel like I got more out of this than I actually planned for, so thank you all for coming. Before we leave, I want you guys to repeat this word: connect, synergize, impact. So you guys are the next CSI, so okay, not CIA. And I'll just tell you this little story. This is the burden that I carry. When I went to my graduate school in Baltimore, anytime I came out of the lab, I was really devastated about the community. It didn't make sense to me. We were like maybe the #1 public health school in the whole country. Fast forward, I went back to get my master's in public health in Boston. Same thing, the community. So something was not adding up, because a lot of my professors at that time would say, oh, we're going to Asia to do this. We're going to Africa. We're going to those places. And I'm like, wait a minute. Something is not making sense here. We have all this funding, but just step out of the buildings, and it's just unbelievable. And then now I came to TSU, and I'm like excited, like, wow, this is a community where we're going to make impact. And again, what do I see? So we here are the leaders, I feel, that have been called to really connect with each other, which I already saw happening, synergize, because we all doing great work. But clearly, for all these years, the number keeps going up. I cannot explain 56.8 deaths out of 100,000 births. I cannot explain that. Next to the largest medical center in the entire planet. So I'm calling on you to work together with us to connect, synergize, and impact. So thereafter, we'll reach out to each. Now that we've had this big conversation, we would reach out to each of your organizations and meet with you one-on-one And the goal is really for us to make impacts that we can actually measure. A lot of times we write grants, we publish, we do all these big evaluation plans, but at the end of the day, how can we show with our center that we've actually reduced maternal mortality in Houston, in Harris County? How can we really, I think if we start from there, we'll actually make real impact. So thank you all for your time. You get emails from Cecilia, and please fill out the evaluation, but more importantly, we really want to have deeper conversations moving on from here to see how we can really make impact. I also bring greetings from our president, our new president. He used to be the JAG of our country, Judge Advocate General. Now he's President James Crawford here. He's new here and he wasn't able to come. And also our VP Penn Marshall and also our Provost Goodman. So thank you all. We thank also our funding for our research, but TSU funded all of this. So our research funds, our HRSA funds, our research. Give it up for HRSA. So and we really appreciate the fact that we can all come together, but it means we now have to roll up our sleeves and put out those grants to the NIH to partner together. We will move the needle. We will not stop until we see those numbers going down the correct direction, like California did in some other places. Thank you, and we look forward to working with you. Oh, sorry, Dr. Szymanski. Thank you. Thank you so much. You all have a blessed day. Thank you.